All right, welcome back to the Hurwitz Lab, and here we go again. We're getting ready to speak with our favorite college-educated and always funny Dr. Alan Segal, and he's back for another long-form discussion with me. And if you're new to the channel, don't forget to check out our previous Renal Fizz podcasts on water balance, acid base, potassium, and my personal favorite, flow. Also, if you're enjoying these podcasts, please click on the like button and don't forget to subscribe. Today, we discuss acute kidney injury, which is really just characterized by an acute loss of kidney function, but doesn't really tell us anything about the etiology. And furthermore, although we've improved our appreciation for the importance of AKI, other than good supportive care and avoiding secondary injuries of other organs, we really have limited proven treatment strategies. And as a busy clinical nephrologist, I can tell you that acute kidney injury is the most common reason for inpatient consults. And this is especially true in the setting of COVID-19 pandemic. So I'm really looking forward to this important review and update. So buckle up and stick around as Alan helps us navigate the complexities of acute kidney injury, or AKI. Alan, I love getting to see you, and I'm really looking forward to this chat, and especially dinner after.
Well, it's great to be back in the Hurwitz Lab. Remember when you were in the Segal Lab? Now it's great to be in the Hurwitz Lab.
Oh my God!
And the place looks great. And we're getting into the real kidney today. You know, we've talked about the physiology of tubules. We talked about the physiology of glomerular hemodynamics during the flow talk. But now we're getting into disease in the kidney. And as you mentioned, for all nephrologists, this is the number one reason for an inpatient
This
consult.
talk is so clinically relevant. I really felt like all the other talks have been clinically relevant.
They're all clinically relevant, and we can bring all that material to the bedside. But this one really is in the hospital. I mean, this problem's in the hospital.
Exactly.
And so, you know, back in my day, we had crazy abbreviations: chronic renal insufficiency, acute renal failure. Renal people didn't understand. And failure, it didn't matter if your creatinine was 2 or 22. It was all failure. So,
I mean, even during my fellowship, it seems like acute renal failure, I mean, we saw all of this, but it wasn't really a studied topic.
Right. Well, it was a little bit black boxy.
Yeah.
And so, I want to do a comprehensive dive into this.
You want to do a comprehensive dive?
I want to do a comprehensive dive.
Oh, that's a surprise.
And what we wanted, and I brought cases. I just want to mention at the outset, all these cases are my personal cases. These are patients I took care of. Every picture I show of urine or whatnot is the picture I took. So that's why they're not referenced, because we want to be very sure to credit people where
we will credit you.
But I just want to say, when you don't see a credit, it's because it comes from my own pictures.
Your database.
And on this first introductory slide, what you see there is the classic finding.
Let me get our slides up. Perfect.
A classic finding of the muddy brown casts.
Of course.
And, you know, these are the brown cigars. I mean, the urine, look, urine, I can't overstress the importance of urine. Urine comes out of the kidney non-invasively a lot of the time. We're all passing urine. It's painless most of the time. And then it has lots of information in it. And in terms of tests that can be diagnostic, since it's pretty much free when a nephrologist looks at a urine sediment, I don't think we bill for it. It's the if you say what's the least invasive test,
that gives
the
high
diagnostic information that doesn't cost anything, I got to say, urine sediment is up there. And so you see that any nephrology type person sees this picture. You don't even need to tell them anything else. This is acute tubule necrosis, and the question is, what's the rest of the case to figure out why? But the diagnosis is on the slide. The diagnosis is on the slide.
In the urine.
And now that we can put pictures in the electronic medical record, this picture would be at the top of my note.
Right, exactly. It's the header.
I don't make people wait for this. I go, here's the bottom line. Okay, so let's get into it.
Put your pointer on for us also, because I want you to be able to.
So I can do that.
That's good.
Yeah, I can do it. I can do it. There's nothing to point at yet, but that's a muddy brown. That's a muddy brown, and you see they're white. We'll talk more about that. Thank you. So what do we know? Well, you mentioned it already. There's still no great way to prevent most cases of AKI. what are the risk factors? The things that usually sick patients do worse. So older age, ECF volume depletion, diabetic kidney disease, heart disease, kidney disease, liver disease, sepsis, being sick and in the hospital, liver disease, and of course COVID-19. Sicker patients do worse.
Yeah.
And let me tell you what the kidneys don't like. The kidneys don't like the hospital.
Yeah, and I think cardiothoracic surgery is an important, it's like for certain perioperative ones, because
in heart transplant,
like being on bypass.
right, ECMO bypass. So sick patients do worse, and sick patients are found in the hospital, and the kidneys do not like the hospital. Things at the hospital are there's a lot of stuff, drugs and dye and whatever else. None of these things are the kidney's favorite. So what are true nephrotoxins? Now the true nephrotoxins, and I distinguish between two nephrotoxins because you'll see ACE inhibitors and ARBs on the list of nephrotoxins. They're not.
They're they change functionally.
Right. So in the steady state, furosemide or diuretic in the steady state, furosemide, ACEs and ARBs are certainly not nephrotoxins. They're the opposite. ARBs and ASIs protect the kidney and slow the progression of CKD. It would be a funny thing to call it toxin. Right. That being said, the story I tell to help people understand this is when the kids were young, we would take them on vacation and they would immediately discover the pool. And I always told the kids, breathing is very important. Never stop breathing. Continuous breathing is what you want to do. So when the kids were young and they jump in the pool, they come out coughing and they're pointing at me. It's my fault. And they go, why are you pointing at me? And the reason is, I said, Dad, you told us continuous breathing. And I said, you're right, kids, you're right. I said, in the steady state, when you're not underwater, breathing is excellent. However, in the acute, not steady state of going under the water, you have to hold your breath. Right. And that, you know what the kid said to me then? He said, oh, you mean, Dad, like when somebody comes into the hospital with AKI, you have to hold the ASIs in the ARB? I go, exactly.
Yes. I even give patients a sick day plan when they're healthy to say, look, you're on these 3 meds. When you're eating fine and you feel great, no worries. But your sick day plan is if you get any kind of stomach bug or dehydration, don't take the metformin. Hold your ACE inhibitor. Yeah. Hold your diuretic.
Exactly.
So sick day plan.
That's right. These are the steady state meds. Mm-hmm. And when you fall out of steady state, as we talked about in one of our first talks, when you fall out of steady state, the stuff that used to be good for you ain't good, just like breathing underwater is not good.
Exactly.
So ASIs and ARBs are not nephrotoxic in the steady state. Now, radio contrast gets a lot of play because when I was a fellow, so there was a very famous 1983 paper by Susan Ho, who was one of my teachers at Michael Reese in Chicago during my residency. She's one of the reasons I went into nephrology. She's a wonderful, wonderful person. She donated a kidney to a patient.
Wow.
She was awesome. We lost her a few years ago. But she had a very famous paper that came out in 1983 called Hospital-Acquired Acute Renal Failure. Okay, that was before AKI. And radio contrast, the first 2 causes were ischemia and nephrotoxins like aminoglycosides.
Right. But
contrast, radio contrast, and those back in the days where the contrast was older and higher osmolality, and people didn't know how much to give. Anyway, it was the 3rd leading cause, supposedly, or association or cause. And so we all grew up thinking radio contrast bad.
Oh.
But fast forward quickly, over the last few years, it's become more and more apparent with very large studies now, especially when the dye is venous.
Mm-hmm. CT scan in 6 months, right.
That it's really tough to say that there's a high incidence. I'm not saying it doesn't happen, but I don't call it contrast-induced nephropathy anymore. I call it contrast-associated. Something else, because other stuff is going on. These patients are often in the hospital.
Yeah, there were those two big studies in the radiology literature that were basically in 10,000 people. No one author said there was no evidence that contrast nephropathy doesn't exist. Right. And I had a cardiologist tell that to me, and I was like,
well, yeah, but so there are people who believe that who don't even believe contrast-induced nephropathy or contrast-associated nephropathy really exists, and that you can usually find other causes. And I don't know the answer, but it's rare, and it's much rarer than we thought.
And I do think it's what you're saying. These things add up because the second study showed that as you get to stage 4, patients who are sicker patients who got contrast. So there's kind of a multifactorial approach.
Especially if they got cath, where the intraarterial.
Right.
Intraarterial. So ATN, everybody calls it acute tubular necrosis. I have never done that because the necrosis itself, I call it's the tubules that die. It's acute tubule necrosis. It's not tubular stuff. So I call
it's not tubular necrosis.
I call just like I call RTA renal tubule acidosis.
Right.
It's not tubular. The acidosis is not tube shaped.
Oh, yeah. That's great.
All right. So anyway, now again, I already related by the first slide that a full examination of the urine is very helpful. And us nephrologists, we love having. There've been many times where I've stayed at the hospital longer just to wait for the patient to make some urine.
What I would do is a lot of times if I did an ICU consult, I'd call the lab and say, when it's on the scope, call me.
Yeah.
And so because the tech would be looking at it and I'd always come over and they'd be like, who the hell are you?
I never trusted anybody. I always took my own urine.
That's
so I take my urine. So I just wanted to know, to the ICU nurse, call me when there's some urine. I'm coming to get it.
Oh, that's good.
And then there's this thing that came out about 10 years ago now, 2013, called the Furosemide stress test. By the way, have you ever used the Furosemide stress test?
I never.
I'm going to go over that,
okay.
and I'm going to tell you a funny story about it. But it seems to help predict recovery.
That's interesting.
Perhaps better than biomarkers. So we want to talk about that. Now, the other thing that people have to remember is that AKI, even though it sounds like just a kidney disease, is systemic. And it's associated with a lot of crosstalk between lungs and kidney. The body is aware of the fact that the kidney's there, and it misses it when it goes on vacation. Okay, and when I told you when the kids were young, they used to say, "Well, Dad, went to school today," and everybody's asking, "What do your parents do?" And we said, "My father is a nephrologist," and they said, "We don't know what that is." And I told them, a nephrologist is the person who, when the kidney goes on vacation, the nephrologist does what the kidney would do if the kidney could do it. And so that's that. They found that very easy though. Now recovery, luckily the ATN, acute tubule necrosis, the rule is recovery to some extent. But the thing is that for 50 years now, we've been trying to give things that would speed recovery.
Right.
Nothing yet.
No.
Nothing yet. These are the bottom lines. So the prognosis is that recovery in ATN occurs. But it doesn't mean that it's full recovery, but there's a significant, clear, risk of having AKI lead to CKD, especially if it's severe, and I'll show you that. And one important point: the return of a serum creatinine to the normal baseline level does not mean the person's kidneys are the same as they were. Because let's just say there's 1 million nephrons in each kidney, and let's just say you're only using 600,000 of them, because like most organs, the kidney has renal reserve. We can actually measure renal reserve by giving high protein diets. So the kidney can do more than it's showing you. But let's just say that you're only using 600,000 nephrons in each kidney, and your creatinine is 0.8. And then let's say you get bad AKI, and you come back to a creatinine of 0.8. Well, now you might have a creatinine of 0.8, but now instead of using 600,000 nephrons, maybe you're using 800,000. So you're not as good as you were, even though the test looks as good as you were. Okay, so keep that in mind. Here's what we don't know, and this is the thing: we don't know how to prevent it. We say, stay volume replete, and the classic: avoid nephrotoxins.
Right?
No kidding.
Yeah. Hey, thanks, pal.
When the kids go out, they say, any instructions? Yeah, avoid being killed.
Yeah.
Avoid being killed. Yeah. Don't get arrested. So. And the other thing is we don't really have great ways of identifying it before we see a change in serum creatinine. And serum creatinine is like light from the sun. It takes, to go with 93 million miles at the speed of light, when something leaves the sun, we don't see it for, I think, 8.3 minutes.
Yeah.
I think. Anyway, if we don't see a change in urine output or we don't see a change in creatinine, we don't know anything has happened yet, which is bad. And that's why all the criteria are based on serum creatinine and urine output.
And I think your point about accelerating recovery is important, because how you recover has an impact on CKD.
Absolutely.
And so if you can move people into a different phase of recovery, like 48 hours or less, then you're looking at maybe a change in their long-term renal outlook.
Right. I mean, so the good news is the tubule knows how to get better. The glomerulus doesn't. Right. The bad news is the tubules don't do it very fast, or as fast as we want.
Right.
So here is when you were an intern. Okay. When
yes,
you were
I
an intern,
was.
I know you were. When
because you were a first year
attending. So my pal Ravi Tedhani, who is at the Brigham, he had a review article in the New England Journal, and that was back in the days they still called it acute renal failure. You see it's up at
Right.
the top.
No.
And there's the classic that everybody sees in med school or whatnot.
Right.
You know, the pre-renal, and I never like the word pre-renal because pre-renal means you're going into nephrology.
Right,
If you ask me.
exactly.
You
Right,
were
no, that's
pre-renal,
true.
I was pre-renal.
Right.
You'll see what I call it. But and then there, you know, so it's before the kidney, after the kidney, and then in the kidney. And if you're in the kidney, it could be the tubules that die, the interstitium that gets upset, or the glomerulus. And then tubular necrosis or tubule necrosis is split between the most of them being ischemia and then toxins. And we're going to go over that. But this is where we were circa 1996. So the risk factors, again, as I mentioned, here's a little table. I'm not going to read it to you. Essentially, it says sicker patients do worse.
Right.
I don't agree, of course, with, again, we stopped the ARBs and the ASIs, but they're not toxic in a steady state, as we mentioned. Okay, so just take a look at that. The texty slides I want to go over quick because you could just stop the video and look at it. So acute kidney injury, how about it? Well, again, it happens in the hospital for the most part. And regular admission, take all comers, 5 to 7%. I think it may be actually higher than that, but these are what more recent literature says. But in the ICU, it's huge, 30 to 70%. And then, as you might expect, there's at least 10% of patients with AKI in the ICU that require dialysis, and your mortality when you're in the ICU and you have AKI, even without dialysis, the mortality is at least 25%. And when you combine complete kidney shutdown to the point that you need dialysis, or renal replacement therapy, or renal kidney replacement therapy, whatever they call it these days, the mortality can approach 70 to 90%. Yeah. It's really bad. So, and this shows that the body misses the kidney. And, there's reasons, clotho, renalase, things like that. Things that the kidney makes that people mostly don't pay attention to or measure.
For sure.
But I'll talk a little bit about clotho a little bit.
I love clotho.
I know you do. So here's your point. AKI predisposes to CKD. And since I don't see very well, why don't you take a look at this slide and tell me what this slide tells you? You can look at the big board.
Yep. No, I can see it. Okay, I can see it from here.
So what does this slide tell you?
This looks like if there's the more bouts of AKIs you have, the more likely you are to progress to stage 4.
And the more severe each individual. So this is a hospitalized patients that either, quote, didn't get AKI, and that this is their chances of progressing. And you see the more severe the AKI.
So the less AKI, the less likely you are to progress to stage 4.
Right. Although the top line isn't flat. Okay.
Right. No, that's for sure.
It's the control.
Yeah.
So again, even those who have a, quote, full recovery from AKI,
there were 1,800 patients in here.
Yeah.
Oh, that's interesting.
Yeah. And this is about 10 years ago now.
Mm-hmm.
So here's the biomarkers that we have. And what you see there, first of all, is our biomarker clinically is creatinine. And so creatinine, you'll see in the green curves. And look at the time of the injury, which is right here.
Okay.
And look at the time the creatinine starts to go up, which is, this is the AKI threshold, and this is just coming out of the normal range. So it's taking a long time. And there are better markers and things like NGAL.
Yeah, the creatinine's not going up for 24 hours after the black line.
Right.
Yep.
And so, what you've got here is you see these other markers are quite early, but we don't still have a handle on, they're fairly specific. They're early and they're specific, but we don't have a handle yet on how to really use these. And that's where the Furosemide stress test might come in. Okay. But these are biomarkers and urine biomarkers, and people are getting excited about it. But, the thing is, we've been excited about it for 10 years.
Yeah. I remember the NephroCheck guys, which is the NGAL.
I think so.
Tim, too.
Yeah.
And that one was like maybe 5-6 years ago, those guys came to the ICU and they wanted us to start using them in the ICU, but it's never really become...
It's never become so friendly, and this is one of the problems. So we're excited about it. It needs to continue, but it's taken a while. So one point I want to make that I don't think is emphasized too often is that serum creatinine. Creatinine is distributed in all of body water. So when people go to the ICU or come out of surgery and been given huge amounts of fluid, all our IV fluids, none of them have creatinine in it. So for every amount of IV fluid you get, you're diluting your serum creatinine. That would make you think the kidney function is better than it is. You haven't done anything to GFR,
Right.
but creatinine's change. And it's bad when your marker for GFR is dissociated and disconnected from your measurement of what GFR would be. So let me just give you a little quick example. Let's say that somebody's
I think it's one of the worst things because you think of the example of the person whose baseline creatinine is 0.5, and they come in with a severe illness and a creatinine of 1.0 that's perfectly normal and normal GFR, right. And everybody's like, oh, no problem here. The person's got 0 GFR.
Right. The one place they're more sensitive to that is the OB service. A pregnant woman comes in with a creatinine of 1. They are worried.
On top of that.
Okay, so let's take a look at something. And so what you do is you figure out the total body water. You take the sum of their cumulative fluid balance and you divide it by, where they were. So take a 70-kilogram man admitted to the ICU with a creatinine of 0.9. Let's say he gets 8 liters positive fluid balance over 2 days. The serum creatinine increases to 1.1. You say, okay, that's not a big deal. But when you put in the correction factor, you find out that his creatinine really went up to 1.31, and now he does make the criteria for AKI. So that's a very important thing to keep in mind. So the patient does have AKI because he's exceeded that 0.3 we're going to talk about. You couldn't see it because it was masked by the fluid. Okay. So this slide shows that there is a optimal for fluid, and as fluid accumulation increases, there's an increase in mortality among both patients who aren't dialyzed, and of course, sicker patients do worse, or the dialyzed patients do worse. So mortality goes up. There's a sweet spot for fluid balance, obviously, and when you're on either side of it, it's not as good as being where you should be. And this graph kind of shows that too. You see euvolemia in the middle is where both of these curves, and the red curve is an injured heart and kidney. Things are much worse for the injured heart and kidney than for the healthy heart and kidney. And
it happens in a narrower volume status.
Yes. And so there's less play of volume
that
you have to work with when people are sick. And you can see these are U-shaped curves, meaning the Goldilocks perfect is what's right. And either side of just right ain't as good as right. So anyway, this I put up just for people to look at on their own, because this is what happens when it doesn't pay to memorize all the causes of AKI. You can find them anywhere. This is just one of zillions I should show, and this is split into the 3 categories. There's the quote pre-renal, intrinsic kidney disease in the middle, and the post-renal causes, and some list of diagnoses. And this isn't even complete, but it just shows what. There's a long list of stuff, and we have to go through a diagnostic routine to figure out what's going on. And our cases will illustrate that. So I'm going to get right to it. So this is my kind of, as I always taught students, I tell them to try to think of 6 classes of AKI. So the first is hypoperfusion of the kidney. So what everybody else calls pre-renal, I call hypoperfusion. That means the kidneys aren't getting the blood they want. Autoregulation by itself is not good enough because the flow is not good enough. So I'll always couch it in flow. Then there's post-renal, where the ureter, something interfering with the ureters, like a prostate. And that's low, but you can't miss it. And then the other, to round out the 6, there's acute glomerulonephritis, which is more rare but important, and the urine which showed red blood cell cast. There's acute tubular necrosis, which is the most common, as we talked about, 55% of the muddy browns. There's acute interstitial nephritis, which is a small percentage. Again, you don't want to miss it because this is almost always due to drugs, and you might see white blood cell casts. And then thrombotic microangiopathy, an important cause to not miss. If you're looking at a patient and they don't have 1 through 5, think about 6.
And interstitial nephritis is becoming more common now as they're using
more
these checkpoint inhibitors, because that's a big new class of drugs leading to AIN.
Right. So the clinical utility of the fractional excretion of sodium that people use, that can help distinguish between 1 and 4, being hypoperfusing or having tubular injury. But it's not great because ATN is very patchy. And when the urine comes out, it's the urine. You don't know whether it's coming out of the injured nephrons, where the FeNA will be high, or whether it's coming out of the uninjured nephrons, where the FeNA might be low. So it's got its limitations, but again, it doesn't hurt to measure it and see what you're getting. So I want to start off with some cases now.
Great.
And I already saw that the battery is going on this. And so what we're going to do is when
we can take a short break and then we'll come back and
because it's going to go. It's not going to make it. But anyway, let me tell you about a 42-year-old man who I saw came in.
I want to end and watch the battery fade out, and then we're going to come in with the next segment.
Okay. So a 42-year-old man comes to the hospital emergently for a gunshot wound. So this man, very healthy, and we know this, very healthy man. His wife tells us, has all the medical records. He was admitted to the surgical ICU after emergency surgery for a gunshot wound to the abdomen.
Pause.
Our first case is a 42-year-old man with a gunshot wound. And we know from his wife that he was perfectly healthy without any medical history. And he was admitted to the surgical ICU after he had emergency surgery for a gunshot wound to the abdomen. Okay. And in addition to piercing his gut, the bullet nicked a branch of the inferior mesenteric artery, so he lost significant blood and was hypotensive. Upon arriving in the SICU, he was already noticed to have a decreased urine output and a rising serum creatinine, and we were called. So when I took urine from his Foley, the urinalysis was negative for protein in blood, which was good. So he didn't have any blood from the gunshot wound that made it into the urine. Mm-hmm. But here's what his urine sediment showed. Now, I mean, that is the killing fields of, it's a black and white, but you can clearly see that the main finding is these black cigars everywhere. These are the muddy brown caps.
This deserves a table view, Alan.
Table view.
This is the table view. I have to test it out, but there we go.
I agree with you, Craig.
Yeah, it looks good up there.
Table view.
All right.
So that is, I mean, again, this is the classic. And it's a good example because there's not much schmutz otherwise. I mean, this is just basically, and what this is, you know, as my daughter used to say when she used to round with us and look at urine, she goes, I see dead kidney. I see dead kidney. So this is dead kidney. And these are dead. These are, I'm going to show you the pathogenesis of how you get these tubes. Mm-hmm. But these are basically iron-ish stained, not iron particularly, but or iron and
would you say things. Those are tubular necrosis?
I would say they're necrosis in the shape of tubes.
Yes.
In this case.
So
in this
maybe
case,
this
in
is
this
what
case.
they were talking about.
So maybe it's what they're talking about, which is fine.
All right. Well, we'll see.
Take your pick. But what you see clearly is you don't see a lot of blood cells. It's not like he's bleeding. You don't see red cells or white cells. You see one diagnosis here, dead kidney.
Yeah.
And this dead kidney, we know it's acute because he was fine before the gunshot wound, and the gunshot wound, of course, caused ischemia. Right. So on the second hospital day, hemodialysis was initiated because he had oligoanuric, which means not much urine, AKI with volume overload because he got all those IV fluids. And after 5 dialysis treatments, his urine output began to increase. Dialysis was stopped, and he improved over the next couple weeks. And his serum creatinine level improved to 1.1, close but not quite 0.9. And it did not improve further. So he did leave the hospital fine. And, you know, it was a long recovery because he had fistulae and things like that. I think there were complications. But I don't think he's got as many working nephrons as he used to have. And this basically is what's showing what we showed already. And so what I want to show you now is a second case. Right after this case, keep it in mind, fresh in mind. This is a 39-year-old male with multiple trauma, and this is actually the very first patient that I saw as a fellow. So the very first day of fellowship at Yale, I had taken a bite out of a donut. I was being handed the beeper, and it went off. And it said, go to the SICU. And I said, okay, where is it?
Right.
And when I got there, I saw a man who had been admitted for multiple trauma, and it was a very hot day. It was July 1st. So it was 100 degrees in New Haven. And this guy had flipped his Jeep over onto himself on I-95 on a very hot day on July 1st. And he was pinned under it for some time. Oof. Okay? So he was sweating. If he was bleeding, he had other reasons to have low perfusion pressure to the kidney. So he was hemodynamically stable when I first saw him without a significant hypotension, but he had been resuscitated with fluids. And he already, now look at this. This is the first day, and he's already got a creatinine of 9.5.
Something's funny there.
Well, it is and it isn't funny because his he was trapped for a while, and he wasn't making any urine. In fact, I may have gotten the last drop of urine he was going to make. And his CPK level was 519,000. So what happens?
Was he a dialysis patient?
Oh, he perfectly normal.
All right, he was perfectly normal.
So what happened though is that there can be some conversion. He was a very muscular guy.
Okay.
And he had lost a lot of muscle. So he was very depleted in the sense that fluid had gone into his muscles. And he had a big injury to the muscles. So he was a big guy, a muscular guy, but he was already in kidney failure. So he stopped making urine completely. I collected the last 5 mils he made. Urinalysis was negative for protein, but the dipstick was maximal for blood. But the urine sediment showed only muddy brown cast, no red blood cells. Now, why, Craig? Why was the orthotoluidine test
Set
on
off.
the dipstick maximum?
It was heme from his
Well, not quite heme. Myoglobin. Right. So
from his
hemoglobin or
muscle
myoglobin can do it. It's pigment.
Right.
Pigment. In this case, he had such muscle injury. His urine was orange.
Right.
And so this was all, the test goes positive because the orthotoluidine picks up the pigment, but there's no red cells.
Right.
So he had, again, this. And you can even see kind of the orangish urine. But he had this was all over the place. Acute tubule necrosis. So again, you're seeing these big, broad, dark casts, hyperpigmented casts. So a diagnosis of acute now nephrotoxic, probably with ischemic as well.
Mm-hmm.
But again, the injury here, now myoglobin is not the toxin. Myoglobin, you can infuse, it's been shown you can infuse rabbits with myoglobin and it doesn't bother them at all.
Interesting.
What bothers the kidney is when the myoglobin gets metabolized to things like ferrihemate in the presence of low urine volume and especially aciduria, which is a lot of people, they can't have aciduria.
Mm-hmm.
They don't have any buffer left, but those few protons that are getting in there are bringing the pH down. So aciduria and low flow rate of urine promotes the metabolism of the myoglobin to the other stuff like ferrihemate, and that is nephrotoxic.
Right.
He didn't make a drop of urine for more than 3 months. All the doctors, except for one, told him and his family that he would need permanent dialysis until he could get a kidney transplant. Exactly 4 months into my fellowship, and I was following this guy on dialysis, he started to make urine, and a week later was able to come off dialysis. So for 4 months, he made no urine.
Right. All those tubular cells heal and line up, and then someone turns the conveyor belt back on.
Right, and so he came back. We had reason to believe his baseline creatinine was 0.9. His creatinine came back to 1.
Wow.
But he was healthy, but this was very severe injury. And in rhabdo, the rule is recovery.
Right.
I've never seen a patient with rhabdo who didn't recover.
Yeah.
To some extent. So he didn't come off dialysis.
Right.
So here's just a slide that shows different ways that urine can look with muddy brown. You don't see white cells and red cells. What you see, in addition to some schmutz, is these black cigars, these muddy brown casts. Okay, so there's some new definitions of AKI. This is taken from a 2021 review. We used to just have, acute kidney injury 1, 2, and 3. But now you see 3 different 1s and 2 different 2s and 2 different 3s. Because now we realize there has to be a 1S where there's no change. So here's the thing. You've got AKI.
It's like stage 1 CKD.
Yeah.
It's like a risk factor.
Yeah, you don't see it yet.
Right.
So no change in creatinine or creatinine that doesn't change by the 0.3 and no urine output criteria are met, but biomarkers will show the kidney's been injured. And so that's 1S because we have biomarkers. So the biomarkers are uncovering that there is, unmasking that there is injury.
And that would be the goal. That would be the key. That's the ultimate biomarker.
Right, but but they're still not good enough for whatever reason.
Well, I think in transplants now we're starting to get something.
Yeah, I think you're right. So the reason that it's important, I think, clinically, this isn't so tremendously useful because you're taking care of one patient. These are mostly for research to show what happens to groups of people with these different categories. And you can group them because these people have different outcomes. And what I want to show you is this. This is the trajectories of AKI. So what you see here is here's where the kidney function is normal, okay, GFR normal. And then here an injury occurs. And the
Out of
injury,
steady state.
Yeah, you fall out of steady state. No better showing of falling out. I'm
Perfect.
glad you said that. No better showing of falling out of steady state than this. But you either fall out of steady state not so bad or really bad.
Right.
Okay. And these are the 1, 2, and 3. So in 1, there's the falling out of steady state, and you come back essentially to what they think is the same GFR, and you don't develop CKD. And then there's the stage 1 where, worse than stage 1, where you recover, but you still get some disease. And here's the trajectory showing these patients. You can have this, you can be a type 1 or type 2 and have this, you can have this. And then, people who already have CKD, if they have or some people who have a tremendous injury, they end up going on dialysis. So these are you don't know, when you're seeing the patient here, you might be able to say where they are here, but you don't know which one of these trajectories they're going to take. You have to wait a few months. And this is what I'm saying, 90 days. 3 months is our arbitrary time frame.
And you try to help them.
Yes. You try to do everything you can.
Prevent other steady state trajectories.
But you have to keep in mind that AKI has multiple trajectories.
Right.
And it depends on a lot of different factors, including how severe the illness is, where they were before, or other comorbidities. Okay?
Yeah.
So here's again another slide of...
and I think your point with the guy with the creatinine of 9 is also important, because creatinine stinks. Because you also need to know somebody's baseline. You need to know what it was before to know
and I've always
something's a problem.
And I've always been a little cynical about creatinine. I used to tell the students that the reason we abbreviated CR is because the other 2 letters are AP. And so it's not, we've had creatinine for a long time. I mean, there was BUN.
And look, it's the best we can do, and we've learned how to work with it.
There was BUN in the late 40s and 50s. Okay. Creatinine came into vogue in the 60s. We still hang on to BUN. And we're, nephrology, look at it, we're an advanced field. And look at us, we're still, sort of hamstringed by only having, clinically. I mean, cystatin C is another marker that's been talked about a lot for over 10 years. Still, we can't do it routinely at most places.
Right.
But here are the criteria for these different things. AKI, acute kidney disease is now recognized as what's the time period before 3 months when the kidney's not normal after injury, and that's called AKD. That's a new. So there's 4 kind of things: AKI, AKD, CKD, and no CKD. So you can just look at this. These are the criteria people use for studies, I think, mostly. And then the other thing that people use for study is the rifle criteria, again, based only on creatinine and urine output. It's called the rifle because of risk, injury, failure, loss, and ESRD, ESKD. And again, here's the GFR criteria. What happens to the GFR in a certain amount of time, usually 48 hours. What happens to the urine output. And these are people, to get this, these people have to almost be in the ICU, because you're never going to get these kind of ins and outs. But, I have never found this to be tremendously clinically useful, but it's useful for research. And that's where we need to be. That's fine. So again, here's that relationship between no kidney disease, AKI, CKD. It's just a picture. And it just tells you where people can be, and you try to figure out where your patient is. Okay. So here is ATN. This is essentially what happens in ATN. So ATN, you're in your steady state with your GFR of 100%, what it should be. Then you suffer the insult. And the insult can be ischemia or my guy who rolled over the Jeep. And what you have is an initiation where the cells are injured and they fall off the tubule, they fall off the basement membrane. The injury gets extended because there's little tiny clots in the microvasculature, there's inflammation. And then the cells are injured and they dedifferentiate. That's called the maintenance phase, and that's when the GFR falls the lowest. And then what you do is you just wait it out until the tubule starts to repolarize and redifferentiate. And the cells come back. And what Pam Gibson would tell you is she sees mitotic figures. These are the tubules try and work hard to get better. Right. Now here's again this one's an old diagram. It's simple to understand. Here's the kind of new diagrams that people see nowadays. This is from 2021. And you see, I'm not a big fan of diagrams with a zillion arrows, because the more arrows they are, the less we know what's going on.
That's true. There's a ratio.
I mean, it's like this. So you can just take a look at this. It basically, it talks about what happens when the GFR falls and what can contribute to it, what's going on with tubular injury, and then, what else may be going on with sepsis or nephrotoxins, and then, what can happen to the kidney. Now, the kidney can either repair itself, the green, or the kidney there's a new term called, it's a combination of, so there's always been like recovery and necrosis, and there's been apoptosis,
right?
And there's a new word that's kind of a combination of.
Doesn't it have to do with like lysosomes binding with something like phagos?
It's a lot of different
phagosome.
things, but people have a lot of different words now.
There's lots of words.
A lot of words.
A lot of words in nephrology.
But unless you know what the words mean and how they correlate to something, it's not that helpful. Anyway, not everything. Things that there's dead and there's mostly dead. Like in the Princess
but it seems
Bride.
like there are things apparently that the cells do sometimes to protect themselves from dying, like ischemic injury, repeated ischemic injury leading to ATP-sensitive K channels.
I'm going to show you that.
Those kind of things.
Right, I'm going to show you that. And so what happens is, again, it's like Miracle Max and Princess Bride. The cells could look dead, but they might just be mostly dead. And mostly dead means a little alive.
I still want to understand this graph because I feel like this table, it looks like things going to the left. First of all, green is always good.
Green's
and
good.
Red usually is bad.
Yeah.
So it looks like if your fall in GFR happens and then you go to the left to the green part, you have rapid reversal and it's reversible and you get better.
The faster, maybe you want to go to the big board.
Let's go to the big, let's go to the table view.
Yeah, go to the table view.
Table view.
And you can say, that's right. Green is good and reddish is bad.
Right.
And so it's like anything else. It's the duration of the insult and the severity of it.
So if it's going to the right AKI progression, this is getting worse. Now, with that, you can either have resolution and maybe you will get better over time, or you'll get fibrosis scarring leading to CKD and ESRD.
Right.
I see that. So clinical outcomes.
And the analogy,
so I get that better.
The analogy is holding your hand under hot water.
Right.
When the water is warming up, no problem. You can have your hand there forever.
Right.
When it gets hot and your thermal
sensors,
scarring, your trip channels, no, your cells start to get injured. If you immediately move away, the injury is short. Even though it was intense, it was short.
Okay.
And you might not have a lot of death.
Okay.
And so you get regeneration. But the longer you hold it on under there, and you get a second or third degree burn.
Yeah.
I mean, that's why the kidney AKI reminds me of the degree of burn. First degree burn, second degree, AKI 1, AKI 2.
Right.
So it's just duration and intensity.
Right. Leading to either fibrosis or some reversible injury.
And coming back to our electrical analogy, things like intensity are power functions. So intensity is like a voltage times a current, like a power.
Okay.
So that's intensity. So when you take two first order things like current and voltage and you multiply them, you get an intensity or an energy or an intensity. And so the more area under the curve of injury, the more you're going to be red. More and people years ago, not that many years ago, people were talking about working on reversing fibrosis. Renal fibrosis would be great. Take somebody with renal fibrosis and be able to reverse it. I haven't seen too much on that lately. So again, here's a more simplified diagram, the pathogenesis of ATN. And here again, you see the normal epithelia, brush border, the proximal tubule, brush border, apical, pump, basolateral, and then you see that what happens first in the injury, and the injury is first going on or early on, you lose polarity. These are polarized epithelial cells, and the cells get confused, which means that things that are supposed to be on one side get on the other side because membranes, it holds a tight junction together and keeps these proteins on their side, the gate and fence function of a tight junction. This breaks down. And I think the membrane gets injured, and I'm going to talk about that a little bit related to something you did. And so what happens is when the cells get more unhappy, the integrins that are the adhesion molecules that keep them stuck on the basement membrane, and you get this denuded basement membrane. Right. And when the cells fall off the basement membrane, there's back leak because now, one of the reasons to decrease urine output, there's two big reasons probably. One reason is back leak. So the fluid that might be urine is now leaking back across the damaged epithelium across the basement membrane. And these cells that slough off can micro obstruct the tubules. And there used to be, at least not 20 years ago maybe, there was a hope that there was the RGD, which is the amino acid code of these sticky things, and it would make the cells stick together. So the thought was if you give anti-RGDs and you prevent the cells from sticking to each other, like let's say there's a lot of Scotch tape out there, but you put something on all the Scotch tape so the Scotch tape can't stick to itself, then you'll get less likely to be clotted or obstructed.
Right.
And so, you then the cells that can, the cells kind of, the basement membrane tries to regenerate cells and they grow up again and they proliferate and then you get back to normal. Now here is from that same Ravi Thadhani 1996 New England Journal. You see here's the healthy tubule with all of its fancy things on the right surface. Then there's an injury and you see loss of polarity, and this is just the same diagram. And you see denuded basement membrane. Here you see some obstruction in the tubule that doesn't look like a good tube. Yep. And then all of a sudden everything's flat and dedifferentiated.
Right.
And then it gets better. So this is the cycle, and you hope you can cycle the tubule back to health. Notice here's our old GFR, and then superimposing it now is the creatinine. Look, here's the injury, but the creatinine doesn't go up for a while. So the GFR, and I think this is optimistic. I think the creatinine takes a longer time. But you see here the little diagram of the obstruction. Anyway, what I wanted to show you is here's the real kidney. So here is taken from a recent review. You see, this is not how the tubule should look. Look at there's the ATN with CAS, and then here's the flattened, dilated tubes. These are not happy, but they could get better. But this is what the pathology would look like. And we don't usually biopsy ATN. So, so these, again, you try not to biopsy ATN, which is one reason why I make a diagnosis. So here you go.
This looks familiar.
Okay, so you might remember this. It says April 16th, 2001.
Wow.
Look at that right there on the strip chart.
Does it have a time?
Yeah.
10:01:15.
Yeah, this is probably 10.
That's probably 10 p.m.
No, it's not, because I think we had it on 24-hour.
Oh, okay. So that's 3 in the morning.
Yeah, I know. So this is something I'm showing just because I think it's interesting and it shows your work. Right. Is this your handwriting?
Yeah, that's my handwriting.
Okay. So back in the day, just for people that are fancy now, we used a strip chart to follow, in addition to oscilloscope and computer.
That's right.
To make sure that we had every experiment recorded, we used a strip chart. So here there's a patch, and we did a sham wash here. Nothing much happened, the activity of the patch. And then here you'll see something called methyl beta cyclodextrin was added out of a little, remember those little microperfusion syringes that we used to activate by the air?
Yes. Yeah.
Remember that?
That was amazing.
Yeah. So look at this. This is one of the greatest responses I ever saw in the lab, was that shortly after adding methyl beta cyclodextrin, which removes cholesterol from the membrane and makes it more floppy. Right. Cholesterol stiffens the membrane, taking it out makes it more floppy. Yep. And we get this kind of maximal opening of channels, and it just continues. And we were going wild here, and this was a big discovery for us. It was the stretch activated channel, and I'm going to show you a little bit more about that. So look at here. What do we got here?
Hey,
that guy's name right there.
Look at that.
Yeah. So here is our stretch activated channel. What you see here is at the same voltage, increasing amounts of negative pressure cause more channel openings. It's easy to see. And if you want to see that in summary, I believe you made this slide.
Yes, that's a beautiful one.
And you see the typical sigmoid of when there's this is channel activity, and then as we make more and more stretch with a half point of about minus 20 millimeters of mercury, which is not unreasonable for patches, we get more and more activity. So there's no doubt that this channel is mechanosensitive. Right. And we called it a mechanogative non-selective cation channel in the proximal tubule. It was also ATP sensitive. And then we thought that's very important because ATP levels fall in the ischemic injured tubule. Mm-hmm. So let's see what else Craig did. So we made a fast perfusion setup, the two of us, and we showed that we made very quick pressure steps. So here's pressure step from 0 to I think like minus 50 and then back again. And we saw two interesting things. One is that stretch very quickly activated the channels. Yeah. But when the cell was still attached, so the patch is still part of the whole cell, There's the cytoskeleton is more intact. There's nothing's hanging out. There was a delay, and that didn't happen when the patch was just on its own. So this suggested that everything you needed was in the membrane. You didn't need cytoskeleton. That's not to say the cytoskeleton didn't do anything, but didn't need it. So let's see, where does this take us? Because I wanted to show this up because this was, I still think it's the fastest. It was definitely the fastest out there when we built it. And we built it for $50.
That's amazing.
But I think it's still among the fastest out there. And it was cheap. So a channel function is a sigmoidal function of pressure, as we already showed. And here's just to see everything at once as we did a ramp of pressure. Yep. But there could be many, many channels in the patch. So here that look like there's no channels. Then we put a little mouse suction on, a little quick pulse of mouse suction. We open 50 channels, whether it's cell attached or inside out, But you see, when we remove the stretch, the channels eventually close. Yeah. Now, is this piezo? Nobody knows yet, but it could have been. I don't know. Piezo doesn't have to act the same in different environments. So here again is our stretch activated channel and the difference between, and it works both ways. So negative pressure if the patch is inside out.
Is piezo non-selective?
Yeah.
Interesting.
Yes, it is.
Wow.
Oh, yeah. It's also closed by gadolinium and spider.
And it won the Nobel Prize.
Yeah, it did.
And look at our pictures.
I know,
Alan.
I know, Craig.
I'm going to give you a prize.
Okay. So anyway, here what we showed that was interesting was when you excise the patch the other way. Now, it's not sensitive to negative pressure; it's sensitive to positive pressure. So we reverse the polarity of the membrane. So when the membrane bows out, whether suck back on the pipette, negative pressure for the inside-out patch or positive pressure for the outside-out patch, we get the same thing. So this was really convincing that we had a stretch-activated channel. Now here's the spider. So this is a tarantula, or this is a Grammostola spatulatum, but this is a rosea. But we got venom from granulosa spatulata. And basically, if you put the spider toxin, if you backfill the pipette so the spider toxin slowly gets to the patch, it kills the channel. So here's a patch where we got plenty of good channel activity. And then after a certain amount of time, when that spider venom moves to the membrane, channel gone, and never to be heard of again. Never to be heard of again. So here's just in our paper, we showed control. So we could have channels working for what's here.
372 seconds.
372 seconds. The channel is still fine and alive in the cell attached patch. Here's what happens after spider venom. The channel's full blast early on, and that venom gets there, and boom, it's gone forever. And nothing. What we did was we also did experiments. We couldn't get spider toxin irreversibly close the channel, and even remember methyl beta cyclodextrin, which would take the cholesterol, would activate the channel. When spider toxin's there, methyl beta cyclodextrin does nothing. So here again, and I'll just show you the cholesterol data again. Here is what's happening with putting on membrane cholesterol, depleting membrane cholesterol, and it opens. And then here what happens when we reverse it. So here's a patch where we have controlled activity. Here we add the 5 millimoles of methyl beta cyclodextrin, and the channels are going crazy, crazy. Here we add cholesterol back to the patch. And after a little bit of time in cholesterol, close again. Here we make a second application, taking the cholesterol out. Open again, same. Here we put the cholesterol back, closes up. Here we take the cholesterol out. So we could turn on.
Totally reversible.
So the channel is off or on, like full off or full on. Full off with cholesterol there, full on with cholesterol depleted, and we can go back and forth. We could control this. And this was fantastic. Yeah, I think we did great work here. I mean, I don't want to, I really do. I think we did very good work here. And these are excellent recordings. And I think, again, this was certainly the time you were in the lab. I think this was your experiment, but I'm not really sure. So how does this fit into ATN?
Yes.
So the way it fits in, I'm going to bring
it
into my own slide of the molecular pathogenesis. So here you get kidney injury, toxic or ischemic. And there's a hemodynamic vasoconstriction that can happen, that can decrease blood flow to the kidney. Then, as you mentioned, when the cells aren't getting their blood flow, there's an ATP depletion. The ATP depletion can lead to necrosis or apoptosis, and dead cells detach. Now, those dead cells detach, leaves denuded basement membrane that must be reepithelialized, and this is where the back leak comes from. Now, the other thing that happens is that if the injury is sublethal, not terrible, what you have is this viable cells may detach. I mean, they're still viable, but they're detached now. And so these can aggregate and cause intratubular obstructions. You got the back leak and the intratubular obstruction.
Mm-hmm.
Now, back leak and oliguria, that explains that. So the other thing that can happen is the membrane's not happy, and cholesterol content of the membrane may change. So here's what can happen there. So we already know that if there's changes in membrane cholesterol, and along the way, this is also the case if there's resilient subpopulation of cells that stay attached to be able to repopulate. Growth, in the presence of growth factors, there's going to be repair. There's partial recovery. You're not home yet. And, there's proliferation and reepithelialization happening. Now, this is, again, the picture that we just showed. But this membrane, going back to the membrane cholesterol, this stops the back leak once you've got some cells there. And where our channels come in, this brings you, when ATP levels fall, one protective mechanism the cells may have that may help protect some from dying is KATP channels will open in response to the injury, and so will non-selective cation channels that are ATP sensitive. For two reasons they may open. One is they may open because ATP levels are falling, and two, they may open because the membrane cholesterol may be getting depleted, and we know that it opens it. And the combination of all these things bring you home to full recovery. So this is my way of thinking about it. I made this slide years and years ago. I made this slide when you were a fellow. After we saw these channels, I had made this slide. Now, after I saw these channels, I just wanted to put it in because people don't talk too much about lipids and the membrane in AKI.
I mean, it certainly makes sense that things are ATP regulated in the setting of ischemia are going to be
maybe protective.
Right. And in repeated, if those things are trafficked into the membrane, like what we see in cardiac disease with people who kind of have repeated ischemia, then they may be somewhat protected.
Yeah, I think that this is a hallucination.
It's a preconditioning.
This is a hallucination. That's right. It's a preconditioning. This is a hallucination of mine, but there is evidence for this, and our own data is the yellow stuff here. So I just think it's keep in mind, since we still don't know how to accelerate repair from AKI, it could be that channels are part of. I won't be surprised at all to find out that something that manipulates channels ends up, especially channels that are sensitive to energy levels, it turns out to be a treatment.
An important part of it.
Yeah. So sure. I just, and this is the synagrins, the RGD sticky peptides. Anyway, so here's back to our case of AKI. Let's get back to some cases. All right. So before we do, I want to mention the furosemide stress test because the furosemide stress test is what comes up when your AKI is due to ATN. So here is the first paper, Greg. It was in Critical Care in 2013, development and standardization of the furosemide stress test to predict the severity of acute kidney injury. Now, I'm going to tell you a story. Back when I was a fellow a long time ago, okay, so I was a fellow in the late 80s. What we would do, called to the ICU for an oliguric AKI patient, first thing we would do, and we were never afraid of furosemide. If somebody had a decreased urine output and they weren't volume depleted, we would hit them with 120 to 200 milligrams of Lasix.
Yeah.
And people would say,
unbelievable, right.
You want to give enough furosemide to block all the transporters.
Right, exactly.
Yeah. And if it doesn't find the binding site, it's not going to do anything, pretty much. So just from common sense, the whole thought was if you could make oliguric non-oliguric, and Lasix was the thing, or furosemide was the thing we did, and we gave that kind of a dose.
Right.
Now, little did we know
that you were doing the furosemide stress test.
We sure were. But you see, we didn't there's a lot of stuff we just do and we don't think about it and we don't say, okay, let's study this. So a full, 25 years later is the furosemide stress test. So I laughed when this came out because I go, oh, this is new. Oh, I've been doing this since the beginning of my career. So, but now it was studied. So let's just see what they found.
Yeah, let's see what they found.
So here's the protocol. The furosemide stress test clinically is used in the oliguric patient to determine whether the underlying kidney tubule function is intact. And here is the dose. If the patient has never seen furosemide, you administer furosemide at 1 mg per kg. So that's not even 100 milligrams if a person doesn't weigh 100 kilograms. So that's a low dose.
Right.
And then if they've seen furosemide before, you give them 1.5.
Right.
So take a 100-kilogram person.
Right.
The most they're getting is 150.
Right, exactly.
We used to give 200.
Oh, my God, that's nothing.
Okay, and then here's your test. The test is simple as can be. You wait 2 hours. If the patient has produced more than 200 mils of urine, they've passed the test.
Right.
And that indicates that tubular function is still kind of intact and kidney recovery is more likely. If the patient fails the furosemide stress test, and you got to do this when
Did they show this out? I mean,
yeah.
Yeah, all right. Well,
If the patient, these are based on studies. If the patient fails, you got to make sure you only give it when patients are not hypovolemic. Then the patient fails, and this predicts more severe AKI and also predicts dialysis. How good are they? And of course, don't use the furosemide stress test in the setting of hypovolemia, and be sure to replace any losses that result from the test. If the patient you don't want to make the patient
deplete them.
Right. So basically, there's 4 ways of looking at the furosemide stress test. The furosemide, furosemide doesn't get filtered. It's highly protein bound. Mm-hmm. So it has to be in the afferent arteriole to go through the glomerulus, to not be filtered, to make it into the efferent arteriole, to then be secreted into the tubule, the proximal tubule, by special transporters, O transporters, that transport the furosemide. So this is one. So they're saying that the furosemide stress test gives you 4 kind of things. Is this intact? Is secretion intact? This isn't tubule. This is vascular.
Right.
This is perfusion-y. This is tubule secrete. This tells you whether the triple transporter is working, and then the diuresis, of course, is the result of all that. So this is their figure. I mean, I took this from their paper, and this is not an old paper. This is, look at that.
Jeez.
Okay, this is what's happening. Okay, so all I wanted to say is that that's the furosemide stress test. We've always been doing it, even more than that. But what they showed that they're excited about is that now studies from all over the world, and there was multi-center studies, that apparently said that the furosemide stress test beats biomarkers for predicting outcome. And that's what makes it exciting. So now that they've protocolized it, even though we did it, we were just doing it on a patient by patient, but now that they protocolized it, it's something that we should pay attention to.
Because for a long time, there were studies on loop diuretics, and none of them ever showed really any benefit, even meta-analyses, whether there was any predictive value.
Right, but that's because those were small studies.
Right.
You got to do it in multiple centers with standard protocols. You got to have a lot of data. Okay. Now, before we leave ATN, I want to mention an important study. As you know, we've often talked about, can we improve the pathway of dialysis-dependent AKI, especially in the ICU where the mortality is high? Can we make a difference in people based on when we time giving them kidney support therapy? So this is a paper from 2020. It was from 2020. And what it shows is this. So I'm only going to show this one slide. This is the survival at 90 days of patients who were started on accelerated or early renal replacement therapy versus the standard. And those 2 lines are superimposable.
Right.
So what this tells you is, and this is not surprising,
right?
Dialysis, in the form of dialysis, in fact, the accelerated may be more dangerous because here's the side effects. Here's the forest plot where you can see they're pretty much
just no signal.
They're canceling. There's very little signal. And then look at the side effects. So the significant different side effects is almost always in the accelerated folks. So standard therapy, I think, this was making the argument that when you're accelerated, you're in a hurry, you get more complications. What are the things? I can't see it. What are the things that are more complicated, that are more statistically significant side effects of accelerated?
Right, hypotension.
Yeah, as you'd expect.
Looks like allergic reaction.
Yeah.
Yep. And
no, allergic reaction is 1. It got to be less than 0.05.
I'm just looking right there. Oh, I'm sorry, I was reading the wrong line.
You're reading the wrong
line. Bleeding.
That doesn't make 0.05. You're looking for less than 0.05.
This is too small, Alan. I can't see it from here.
Yeah, it turns out that the ones that are hypotension, so any adverse response.
Decreased phosphorus.
Yeah, any adverse effect was more common and accelerated.
Right.
But things like hypotension, things like decreased phosphate.
Yep. That looks like it.
Yeah. And then other things like infection got a little close. But in other words, the outcome's not different. So use standard is what I think this paper is telling us.
Right.
And it must have been done in a lot of people and carefully because it's in the New England Journal. So there you go. So now let's come back to cases. I'm done with ATN. Okay. I'm done with number 4.
Right.
Okay. Now we have a chef. So this is a guy from Vermont. Healthy 33-year-old chef is admitted for a week of low-grade fever, malaise, and mild shortness of breath. He reports cutting himself prior to the illness while trimming organic chicken breast. We took a very careful history. What exactly?
It was organic chicken breast.
Yeah, he said
it was breast, not leg.
Yeah, he said it was chicken breast, and he was very careful. It's organic.
Right. Yeah.
I make only the best stuff. So he delivers it fresh to a nearby farm, but he is unprocessed chicken. And even though he got a cut on his finger, he washed it under running water, but he developed an infection of the finger. So in the emergency room, his hemodynamics were okay, except he had a fever of 38.6. And his exam was normal, except for what seemed to be possibly a new murmur, and he had splinter hemorrhage. So this is highly suggestive of infective endocarditis. And the finger, of course, had cellulitis extending into the palm. Now, his white count was elevated, a little bit of anemia, and his creatinine is 1.2, which probably was a little bit elevated for him, but we didn't have any previous values. Blood cultures, not surprisingly, 4 out of 4. The good news is it's MSSA. The bad news is it's 4 out of 4 bottles.
Right.
And he's got a veggie.
Right.
So the chef has a veggie. So he's making a diagnosis of endocarditis, and he was started on ampicillin. And I want to point out that at this time, this happened, it was after you were a fellow, but not that much after. Maybe 2006.
Okay.
And the story here was, at that time, ampicillin was on the list of not so bad.
Right.
It was on the good list, not the naughty list of, where methicillin's on the naughty list.
Exactly.
Methicillin's very naughty. Ampicillin's on the other side of that. So here's what happened to him. The day following admission, his creatinine is elevated, and look what happens. A nephrology consult is called because over the couple of days, his creatinine just shoots up. Okay? So there we have it. That's definitely AKI. And this is assuming he was normal.
Right.
Now, here's the urine that we looked at. Now, again, I love this.
Cellular cast there.
This is, and this is a cast. You could clearly see the outline of the matrix of the cast, which is hyaline, which is Tam-Horsfall protein, and you see it's stuffed with white blood cells.
Right.
So this is a white blood cell cast in this guy. You don't see muddy brown. So the diagnosis is AKI due to acute interstitial nephritis. Note how the urine gives us the diagnosis. Urine gave us the diagnosis, like it did for the ATNs. So here is the big list, and there's a zillion of these. I just picked one of these. These are the list of the medicines that don't get along with the kidney. And let's just say there's a lot of them, okay? And they can make you unhappy with interfering with circulation, like NSAIDs. They can make you unhappy inside the kidney with ATN. They can even affect post-renal. And there's a zillion.
Oh, yeah.
Excuse me, a zillion of these. And so, and acute interstitial nephritis is a zillion. And most of them are antibiotics or proton pump inhibitors. So the big ones here are the antibiotics, okay, and the proton pump inhibitors. Proton pump inhibitors may actually be taking over the number one cause. Do you see ampicillin on this? No. So you see methicillin, should be there. Because methicillin, we don't even give methicillin anymore. It's so bad. So it didn't make the list because nobody gives it. But beta-lactams, okay, are on there, and the cillins. So here is a study from about 5-6 years ago where they looked at the causes of acute interstitial nephritis in the elderly. And what you see here is that antibiotics lead the way. Proton pump inhibitors are second, but they're gaining, okay? And then there's a smattering of other ones, okay? But, AIN is usually due to a drug, the kidney not liking a drug.
That's it. We look for all the things that happened in the weeks right before this happens, if it's outpatient or other things. I just had a case of a patient, like I said, getting a checkpoint inhibitor, for cancer.
Yeah.
And, they developed kidney insufficiency, white cells, it was interstitial nephritis.
Right. So here is the pathology on kidney biopsy of, and what you see here is the tubules look okay. The problem is not the tubules. So the gloms look fine, and the tubules are still back to back. And where the tubules aren't back to back, it's because there's acute infiltrates.
Right.
So there's white cell, and this is in the interstitium. I mean, there's not the interstitial is supposed to be a small space in the kidney. It's a space where the concentration is happening, so we got to keep that volume low. We'll talk about that in the countercurrent multiplier talk. But what you see here is all sorts of patchy infiltrates, of acute infiltrates that are causing edema. So this is the interstitial nephritis. There's cells and there's swelling and there's keeping the tubules from being together, and a kidney unhappiness develops. But the gloms and the tubules themselves are fine, okay? So what we happen to have, I don't know what it was, but in this year of the chef, we actually had 4 cases come to our hospital.
Wow.
And your good old friends, Tobin
and
Marios. Yep. And I, we were impressed by the fact, because everybody from IG.
Maybe you guys had a bad lot of nafcillin.
We asked if we could have. I mean, we published it irrespective. We said either it's bad nafcillin, or either nafcillin's bad, or we got bad nafcillin.
Exactly.
But that year, there was a lot of cases after ours that were reported when they saw this. So there might have been a bad lot of it. Who knows? But the bottom line was they had nafcillin, and they did badly. And how can we prove it was nafcillin?
Right.
So we thought we had 4 cases in the same year, and this paper came out in 2007, so the year was 2006. This happened. So here again is the case, a typical case where creatinine was fine, then nafcillin was started, and it wasn't fine. Nafcillin was stopped, and it improved. Then we had a case where nobody believed us. So nafcillin was started, stopped. Kidney improved, and they said, no, nafcillin should be fine. And they restarted it. I love it.
That's a classic. Nice challenge.
It's a challenge. It wasn't our idea, but we said.
What did they know you were writing the paper?
They must have.
Hey, that's good.
So all I know is when writing the paper, I was very happy. I wasn't happy about it, but I was happy about it that we had it. But that's what happened. So clearly, this shows you it wasn't just true and unrelated. It's true and related. Right. And you know, the each patient had beautiful casts. So the urine gave us a diagnosis. Okay, so that's what I wanted to say about AIN. Okay.
Oh, one other thing I think interesting about your nafcillin case. Yeah. With the endocarditis, is endocarditis is funny because it can cause another type of acute kidney injury as well, which you're probably going to talk about. But you know, immune complex, but it brings into the timing of acute kidney injury, and it's always the story.
That's why the biopsy. That's why the biopsy helped us.
Exactly.
So you're right. The differential diagnosis of kidney dysfunction in infective endocarditis is wide. Everything from sepsis to post-infectious to infectious. It could be glomerulonephritis. That's why we did the biopsy. Right. I mean, the urine was not it wasn't a GN urine.
I mean, if you were pure interstitial nephritis with a new medicine and it was totally clear, maybe you wouldn't biopsy.
Right.
But with the question of these other things,
I think it was the compelling. The reason for the biopsy in the chef was because it was compelling. I mean, we just had enough. People we didn't need a biopsy. Right. Nephrology wasn't saying biopsy. Right. Okay? But people wanted.
But in that case, I can see that it would be good because there's two important things to differentiate.
But we weren't surprised because we saw the urine.
Exactly.
And we didn't see blood or red cell casts. And, you know, so it would have been a weird GN. Right. And by the way, his complement levels were normal.
Right. And there you go. So that's the beauty of these things.
So put it together, Craig. I present you a case of the chef. I tell you his complement levels are normal. I show you his urine. Yeah. I tell you he's been on drugs, antibiotics. Are you going to be pushing me for a biopsy? No. Probably not. No. Especially when I tell you there's
get rid of the offending agent, you watch the creatinine get better,
and then
don't give it back.
They'll give it back. Yeah, exactly. Beautiful.
I
beautiful.
love it.
Yeah.
Nice case, Alan.
Yeah. So
beautiful paper.
Yeah. So these are it made a decent paper.
Yeah, it's really nice.
Okay. So now moving on to the next case. Now here's one of my favorite people. He's a New Yorker. The guy was a New Yorker when I met him. And he came into the hospital, admitted to the cardiology floor because they thought he had decompensated heart failure because he was edematous. So the presumed diagnosis was decompensated heart failure, CHF. He had high blood pressure and edema. On physical exam, he was hypertensive, and he had this guy had bad edema, okay? And his admission lab showed a creatinine of 3.6, which was, we didn't have a lot of data on him, but this was bad. But here's where we did a fractional excretion, and it was 0.4%. Okay. So here you have a guy with, quote, bad heart failure, a creatinine of 3.6, which is pretty bad kidney injury, and a low fractional excretion,
Okay.
you wouldn't expect to see muddy browns in his urine.
Right.
Okay. So what did his urinalysis show? So his urinalysis showed very high, the maximal test for protein, okay,
Yep.
and large blood.
Yep.
And I couldn't wait to look at his urine. So I got his urine. There's his urine. Okay.
That's urine. You sure
Now-
it's not a stool sample?
Now you see, I didn't change any colors there. There's the orange top. You know
Right.
that's it, the orange top.
Mm-hmm.
That's the counter.
Okay.
Now, what color is it? I mean, sometimes people say iced tea or Coca-Cola colored. To me,
just-
that looks like I used to make chocolate phosphates in my first job as a soda jerk. To me, that
Mhm.
looks like a chocolate phosphate.
Could be.
Where you put Bosco at the bottom of chocolate syrup at the bottom of a cup and put in seltzer. So what is that? That looks like, some pretty bloody urine.
Yes, it does.
Okay.
Yep.
So under the microscope, what's it going to look like, Greg?
It's going to look like blood. Let's see. Hey.
Now, but also what you see here is, if you look closely, you'll see, I didn't label them, but you see dysmorphic
Red
blood
cells.
Red cells. So
Yeah.
this is gross hematuria, but this is hematuria where the cells have been beaten up
Yes.
inside the glomerulus and
Mhm.
beyond.
Right.
This is not a kidney stone where you get beautiful
True.
Dunkin' Donuts.
Right. It's not lower tract bleeding.
And so here is we biopsied him,
Oh.
and here's the picture on Telfapad under Pam Gibson's dissecting scope, and even from far away,
It looks inflamed.
I mean, look at this, is terrible. So there's areas that look not terrible. This is the way the kidney biopsy is supposed to look.
I think this is also such an important picture because it makes you realize, and I tell patients this a lot of times, you have a rash in your kidney.
You have a rash in your kidney.
Yeah.
And you're exactly right, Craig. And I don't see, I'm glad that you said you liked the picture, because you don't see in cases, even when they're published.
Yeah.
You-
A
you-
picture of
you
the
know,
core.
You see this.
Right.
You
That's
don't,
true.
You don't see this. You see
Mhm.
the middle, but you don't really see these
Right.
that often.
No, that's true.
You'll see the microscopic of this.
Right.
You'll hear maybe about that.
Right.
You'll see this maybe, and you'll get the microscopic.
But you could
pathology.
imagine
But
that if that one on the right was your skin, a little hydrocortisone, that's
Oh,
going to
yeah,
get better.
yeah,
It's
yeah.
not scar tissue.
Yeah. So let's take a look at when Pam looked at the kidney biopsy.
Let's see.
What did we get? So do you have any presumptive diagnosis?
I actually have to go back to your first slide for a second because I had to run and fix something. So, nope, back to there. Yeah, no, the case. Go
I
back
see.
one.
The
Yeah. So his creatinine was 3.6, 4 plus edema. Okay, low fractional excretion, not very high. Urinalysis, 3 plus protein, large blood. Got it. Okay.
So do you have any, seeing this, do you have any tests that you would like? You want to ask me something? We did other workup.
Yeah, I mean, blood work.
What would you want to know?
Well, I'm going to order some serologies.
What serology would you want
Well,
first?
he'd get an ANA, an
Ag.
ANCA, and complements.
Okay. Negative, normal.
Anti-GBM.
Negative.
Okay. So he's got immunofixations would be standard, but that's not
Negative.
really thing.
Negative.
Okay.
Good. I mean, this is. I mean, I'm
This
glad
is
that
the
this is
standard-
how we talk
Right.
about it in real time.
Right.
This is recapitulating the conversation I had with
Tell
my
me
fellows
more of
in
the
day.
history because I want to know again what happened to him. What's his story?
His story is he's a popular guy in upstate New York.
Okay.
I won't say what his job was because it might be too easy to identify him.
Okay.
But he was a guy who liked a good time,
Mm-hmm.
healthy good time, and he was popular because he did popular things
Okay.
at social
Okay,
places.
but what happened to him? What was his complaints?
Came in all swollen
So
and weak.
Over in 1 week.
No, swollen and weak, developing over a few weeks.
Okay, so over a few weeks he was swelling up.
Yeah.
Yeah, and that was pretty much it. Okay.
And then here's the data.
Yeah.
And so
And complements you said are normal.
normal.
CBC?
So it tells you that because we divide things into low complement and normal complement.
Right,
So he
exactly.
doesn't have endocarditis.
Right.
Okay,
Right. He
or-
doesn't
or
have
lupus. He
endocarditis
doesn't
or
have
lupus.
Yeah.
Right.
So he's got something normal complementemic.
Yeah.
And his CBC, other than a little anemia,
Mhm.
hemoglobin 11, nothing.
Wasn't really anything special.
No, platelets were normal.
Okay. Good. Well, he gets biopsied.
All right. So here's his biopsy. And you see a very unhappy glomerulus here.
Oh, yeah.
Okay, so this is the PAS, the trichome strain, and you see hypercellularity.
Mm-hmm.
The capillary loops are not very well open, and there's fibrosis.
Yeah.
So this is unlike the interstitial nephritis, unlike the ATN where it was all bad tubules,
Right. This
and
is a
unlike the
glomerular.
interstitium in AIN, this is where the problem is not. It's here.
Mm-hmm.
So he's got, he looks like he's got a rash of his glomerulus. What would you call that?
Right, glomerulonephritis.
Exactly.
Hey.
Okay, and so there's the immunofluorescence.
IgA.
This is IgA stain.
Yeah, exactly.
So he presented with bad IgA nephropathy that put him into a fair amount of kidney failure. And the hints that he had GN were there. He was hypertensive.
Right. Right, exactly.
He
He
was
had a
hypertensive.
proliferative GN.
Yeah, he was hypertensive. The FeNO was low.
Right.
Now, why? So one thing that people, so here you got AKI, and they tell you, so so many people take a shortcut and they go, oh, AKI, if the FeNO is low, it's perfusion, low perfusion. And if the FeNO is not low, it's AKI.
Tubular injury.
Yeah. Well, this is AKI. Perfusion's not low. Why is his fractional excretion low? I'll ask you that.
Good question.
Okay.
Not sure.
I'll tell you why. You do know the answer. You just forgot you knew the answer.
Right.
Here's the
That's
answer.
the usual answer.
Yeah, you knew the answer. Because where's the boo-boo? In ATN, the boo-boo is the tubule.
Right.
What do the tubules do? They
Right,
reabsorb
they're
sodium.
right.
So when you lose tubules, FeNO goes up because you've lost the thing that
You
does.
can't reabsorb.
But when the GFR goes down, what's the tubules response? If the tubules are healthy and the GFR goes down, what do the tubules do?
They're going to hyper.
Exactly. They're trying to correct that.
Yeah.
So since all the pathology here is the glomerulus, so when the AKI is due to GN, yeah, the FeNO is
can be
low.
low. Right.
Exactly.
Right.
This was a, I loved this case from the moment that I loved him. I loved his urine.
Right.
I loved that he was on the cardiology floor.
Right.
Where the last thing they want is an IgA-GN. And that's what it was. So here's what happened to him. A kidney biopsy showed that he had severe IgA glomerulonephritis with a nephritic and nephrotic. So his nephrotic was edema. He did not have CHF, which is why his echo was normal-ish. But he was nephritic, edematous because he was nephrotic and IgA nephritis. And again, he had the hypertension, he had the hematuria. Blood pressure is high because he's trying to hyperreabsorb. Hematuria, dysmorphic red cells, decreased GFR. And again, we talked about the FeNO being low. He did not tolerate treatment with glucocorticoids. And so he could only be treated with loop diuretics for the edema and ARBs to try to slow down the proteinuria. And over the next 8 months, he progressed to ESKD and went on dialysis in New York. Yeah. So you actually may know him.
Oh.
But I can tell you later if
Yeah.
you know him. But anyway, that's what happened to him. So now we've covered. So what we've covered, I didn't cover in detail hypoperfusion because it's obvious. We've covered GN with this guy. We covered the ATN. We covered the AIN. I wonder what's left. So let's just see. Here is a case I saw recently. A very nice 25-year-old guy who presents with kidney failure to the hospital. And he's admitted to the hospital following 10-day illness of an acute GI illness. His urinalysis showed 2+ protein, not maximal, but it was there. An examination of the urine sediment showed bupkis, really. Okay? So no red cell cast, no white cell cast, nothing that was going to tip us off. His blood test tipped us off, though. He's got anemia, thrombocytopenia, and an elevated LDH. So and then the peripheral blood smear shows cystocytes.
Right.
So he's got what they call MAHA, microangiopathic hemolytic anemia, which explains the anemia and the schistocytes and the LDH. And he's got thrombocytopenia along with this. His serum creatinine was 12. And we know he didn't have that. And then the key test.
That wasn't his baseline.
Yeah, the key test, it takes a while because it's a send out to Mayo. The key test was the Adams
13.
TS13 or T13, whatever. It was normal. So this could be, when you're seeing the case, it could be TTP, thrombocytopenic purpura. Okay. He didn't have any skin lesions. But TTP patients don't have a normal They have a low.
Right.
So
they
here,
have a low.
so here's his kidney biopsy.
Complement mediated.
Yeah, here's his kidney biopsy. So the trichome stain of the small renal artery. So here's his arteries. It's blocked. So he's got a microscopic angiopathy because he's got a TMA. That's what this is. The general category is TMA, not the specific. So he's got vascular unhappiness. He's got glomerular unhappiness. And again, he's got occluded. The glomerulus, as we talked about, is the fanciest capillary the cardiovascular system knows how to make. It's also quite delicate flower. And so if a small renal artery is, which is more robust, is all blocked up, the poor glomerulus has had it. So he's got no GFR.
Right.
He's got no GFR because all his glands look like this. And here's the key slide. The differential diagnosis for the TMAs, which I think is what I want to point out. I'm presenting him as an example of a TMA, but really I present him also to show you that there's a differential diagnosis. So in kids and in adults, but in kids especially, they can have a Shiga toxin, Shiga enteric toxin, and give them a hemolytic uremic syndrome. And again, they present with thrombocytopenia and microangiopathic hemolysis, just like this guy. And then clinically, they can have confusion, neurological. The brain can be affected. Blood vessels go to the brain. The kidney can be, and the gut. So what about this? Here is Adam TS13. You got to evaluate. This is the key thing. You send the Shiga toxin, which for him was normal, and evaluate the Adams TS. Now, if the Adams TS is undetectable or very low, that's TTP.
And that often goes more with neurological symptoms and less renal failure, somewhat.
That could be. But this guy had normal.
Right.
So he goes right to the atypical HUS, which is what he had. He had atypical. And atypical HUS, people are genetically predisposed to it.
Right.
The first case I saw was a 33-year-old woman who was fine and dandy, and she had a baby. And after she had a baby, she had kidney failure.
Wow.
Seizures and kidney failure. She ended up having atypical HUS. And she was the first patient I treated with eculizumab.
Wow.
And she was on dialysis when we started, and she came off. Without eculizumab, nothing happens to these people are on dialysis until they get a transplant. So eculizumab, what happens to these people is they're born with the genetic mutation of the complement system, but they need a second hit. For her, she was fine for 33 years, and then her second hit was pregnancy. For my guy here, he was born with it. His second hit was the GI illness.
Right.
Surgery can tip it off.
Yeah.
We've seen people be fine, and then they have surgery. So I've seen it happen in pregnancy, tipping it off. I've seen it happen in acute GI illness, tipping it off. I've seen it happen in surgery, tipping it off, and I've seen it happen with substance abuse, tipping it off.
Yeah. We had one case with a GI tipping it off in like an 18-year-old who was on a trip.
I know that patient.
Yep.
Okay. So the key here is the Adams TS13, the Adam TS13. When it's low, it's TTP.
Right.
When it's perfectly normal in the otherwise setting that looks a lot like could be TTP, it's atypical HUS. And for these people, eculizumab is the stuff. So he was started on acute hemodialysis. And I met him. He was on dialysis. He was put on dialysis the week before I was on call for a weekend. When I saw him on dialysis on the weekend, I asked him how the eculizumab was going. He said he'd never heard of it and nobody ever talked about it. On that Saturday, I made sure he got eculizumab. So I put him on that on a Saturday.
Wow.
And I called a lot of people. I said, I know it's Saturday. I know we're busy. This guy needs this drug today. And the difference is, the thing I ran into was interesting was they said, well, he's an inpatient. And the cost of it is different for an inpatient and outpatient. I go, the guy, he needs it. Anyway, after 2.5 months of getting eculizumab, he came off dialysis.
Interesting.
And they don't come off without it. Everybody I've started on eculizumab has come off. And there's a new drug, the new generation eculizumab, it's a bit longer lasting. So people don't need weekly.
Every 2 weeks.
It's more like 2 or 4. And so they don't need it as often. It's more expensive, but if over time it's less expensive. So there's the 6 classes of AKI that I talked about, and I showed you cases. I didn't show you a case of this, but I showed you cases of all these things. There's one thing left, and that's our last case. A 60-year-old man presents with kidney failure, and I like this case. 60-year-old farmer who lives near the border of Canada was admitted to the general medical floor after collapse in his own field. not in the field, in his field.
Right.
Okay. He had been gradually feeling worse with a decreased appetite, losing weight, and some confusion for more than 6 months, but he just kept working because that's what these guys do. And his family thought he should see a doctor, but, there are places in rural where, I'm fine unless I'm dead.
Yeah, that's it.
Well, he again, he had not noted any change in urine output, and you're going to have to explain that. So on physical exam, he was hypertensive, but otherwise the physical was unremarkable. But the lab showed a creatinine of 20.
Oh.
Okay. And the urine studies were unrevealing, except he had no ability to concentrate his urine. Imaging showed severe bilateral hydronephrosis, along with shrunken, scarred kidneys. He probably was obstructed for more than a year.
For a long time.
Because we know for sure 3 months, which sounds like a long time, people recover. But when it gets on a year, that's why it's important to always look for this. Because if they are obstructed, interventional radiology or urology can unobstruct them, decompress the urinary tract. And people can be obstructed for up to 6 months, I've heard. And
I think in dog studies, when they fully tied them off completely, it was like 2 weeks. And after that, they didn't recover. Right. But partial obstruction, if there's just back pressure.
So this guy's got a creatinine of 20.
Oof.
And scarred kidneys that are shrunken.
Oh.
And a dilated urinary system.
So what did the biopsy show?
Just kidding. How do you explain the fact that there was no change in his urine output?
Well, I mean, he was still able to, his volume, he was still able to filter and, excrete his.
But why? I mean, obstruction makes people think that there should be a drippy faucet.
I see. Yeah. No. I mean, I think, he still had output. He just had a high back pressure.
Well, I'm gonna tell you that's true.
He wasn't fully,
that's true.
He reached a steady state of a pressure that overcame the obstruction enough to allow him, but at the expense of having 7 liters of urine in his bladder.
No, he didn't have 7 liters.
Or how many liters he was running?
Not many. He got a normal urine output. No. Pretty normal. The reason is this. We talked about this a little bit, but let's say, you have to make enough to stay in steady state. You knew I was going to come back to steady state.
Yeah.
To stay in steady state, you not only have to excrete the water that you eat and the sodium that you eat, you have to excrete all the solute that you're making. So let's just say for just example, let's say his solute load is 800 milliosms per day.
Right.
Okay. And let's say he can concentrate to 1,000 at the tip of the loop of Henle. We'll get more into this with countercurrent. Then if he can get 1,000 milliosms in a liter, to excrete 800 milliosms only takes him 800 cc's. Okay.
Right.
Now let's say he's obstructed and destroys his collecting duct and his loop of Henle. The whole concentrating system is gone.
Mm-hmm.
He can almost. His sphere of gravity is 1010. Now he's still able to maintain the steady state of getting rid of the 800. But now instead of being able to concentrate to 1,000. Let's say he can only concentrate to 400, and that's generous.
Right.
Okay. He now can stay in solute balance by just getting rid of 2 liters, because 2 liters times 400 is 800 milliosms.
Right.
So actually, the symptoms of prostatic hypertrophy and even obstruction to the bitter end can be no change in urine. Because the family said he can't be. The family said to me, "Doctor,
he can't be obstructed.
He can't be in kidney failure because he's making urine."
Right.
And of course, we understand that doesn't.
But
matter.
I would think that if it was prostatic hypertrophy, it would be what's causing the obstruction is back pressure, and that has to happen after the bladder is expanded.
No, what's causing that? It's causing that. The reason that you get bilateral hydronephrosis, the way I look, I'm not saying you're wrong.
Yeah.
The way I look at it is, you're not going to be surprised to find out the urine flows. You cannot get hydronephrosis unless urine's flowing. Because if urine is not being made by the kidney, there ain't nothing driving the hydronephrosis.
No, that's for sure.
So what's happening is the membranous urethra is being strangled by the prostate.
Yes.
Okay? Not completely.
Yeah.
But enough that it's an obstruction of flow, like you grab the hose.
Right.
And so if you grab a hose that's got flow in it, the hose expands.
Right.
That's hydronephrosis.
Exactly.
Hydrohososis.
Right. Yes, actually, yes, right. Exactly.
And so the fact that he was still making urine, you can't get hydro if you're not making urine.
No, that's for sure.
Yeah. So you need 2 things to make hydro. 1, you need to be making urine, and 2, the ureters have to be able to expand.
Yeah.
So in the rare cases, they can't expand, and you can get non-dilated
obstructive
that's
uropathy.
rare.
Right.
That's rare.
Yeah, that's rare.
But he had fine ureters and he was still making urine. So he had the
Yeah.
bilateral hydro.
Interesting.
So it wasn't pressure. It was obstruction to flow, which are
Yeah.
different things. Because
Yeah.
it was the obstruction to flow. It was flow is primary. I tried to convince you of that. And now you've obstructed it distally.
What causes the tubular injury in the collecting duct?
Oh, now so that's actually debatable. In the early days, it was just simply the simple hand waving. It was a hand waving explanation. It was pressure, but the increased pressure. I actually don't think, I'm not saying that did any favors.
Yeah.
But the pressure equilibrates. The kidney doesn't explode.
No, it's not going to explode.
It's not that. No, what I think happens is a happy kidney, one of my professors once taught me this at Yale, a happy kidney is a urine-filled kidney. Okay?
Right,
Okay?
yeah.
And a happy kidney, a corollary to that is it's not the same urine it's filled with. It's filled with flowing urine. And when you got the combination of, whatever is making the collecting system unhappy, the collecting system gets unhappy. Whether that's, initially there is a pressure situation.
Yeah.
And I wrote a paper on this.
Because I would think also if the bladder's contracting against it's path of least resistance.
Yeah.
So if you go to pee.
Yeah, he pees.
And
but once the urine's in the bladder, it's past the obstruction.
It's past the obstruction, but if you're having
it's not going to be
trouble
transmitted
flow,
back.
It doesn't transmit back.
No, because there's a higher resistance. So if anything, it transmits less back.
Because the resistance is in the ureter?
Prostate. Is in the membranous urethra.
Right. No, there's that. So wouldn't it? When the bladder increases its pressure, the ureter,
the regular urethra, the penile urethra,
right,
is where it's going to go out.
Right.
It's not going to backflux. Okay. Especially if you have competent
ureterovesical junction.
So no, but I think it's the unhappiness of a kidney it's chronic kidney unhappiness.
Yeah.
And but nobody's proven that the cellular injury, the reason the collecting tubules give up the ghost. Now, why do they give up the ghost?
Yeah.
Hand waving pressure. I haven't seen proof of that. I think what it is, and there's a big body of literature on this, is immunologic. So there's a lot of data came out of Washington, St. Louis in the 80s, 90s. Good work done at Washington University in St. Louis was putting forth the hypothesis that the real damaging thing in chronic obstruction was the immunologic injury. Okay. And so I easily believe that, because that to me is more compelling than pressure, because that's inflammation. And it causes fibrosis. And he had shrunken kidneys. So now I've had men who developed cretins over 20 over a week. So there was a guy who developed acute urinary retention from some drug. Everything was open, but the muscle stopped working. He basically had a neurogenic bladder.
Right.
And he had liters and liters of urine in his bladder. And it's, again, when you have no GFR and you know the weight of a person, you can see how many days it's going to take them to go from 1 to 20. It doesn't take much longer than a week to go from 1 to, but this patient went to 20 over a long period of time. If it would have just been acute urine retention, he'd have gotten better overnight. So it was initiated on hemodialysis and later transitioned to home peritoneal dialysis. Let's put a shout out to home dialysis. 3 years later, he received a deceased donor kidney transplant, and he's doing well, still working at the farm. I mean, the first thing the guy wanted to do is get back to work at the farm. So this just shows that AKI of any kind, when the kidney's unhappy, look at all the other pictures of the organs. Everything is unhappy. The lungs are unhappy. They can get congested. There's encephalopathy with confusion. There can be, obviously, crosstalk from the heart.
Oh, yeah.
Everything's unhappy. And we know bone and liver, of course. So just to remind you that AKI is a systemic disease. And I'm only showing this. I'm not going to read this. This is just the AKI biomarkers that we developed over the years. And they're some of these are available for clinical use, but we don't exactly know how to use them yet. And like I said, the furosemide stress test, if the furosemide stress test is almost as good or even sometimes better, it's going to be a hard argument. The furosemide stress test people are making the argument.
The only problem is that the furosemide stress test is when there's already evidence of acute kidney injury, and the perfect biomarker is the one that identifies before.
Exactly.
So you admit someone with sepsis, you're doing
the troponin.
Yeah.
Kidney
Instead
troponin.
of watching the urine output and waiting for it to drop to zero and with no change in creatinine, you're looking for, something that predicts it.
Right. So I put this slide in for you from a recent review in intensive care medicine, summarizing the characteristics of available machine learning models. So the idea is,
I think
is for the computer. So what would be the idea here?
No, I think it's great. I mean,
what's the idea though for people that don't know deep learning or AI?
Well, I think the idea is to plug in all the data from, a training set of acute kidney injury with known outcomes and let the computer try to learn what it is about those things that predicts that outcome, and then apply it to another test, another set, and see if it proves to be correct.
Exactly. So it's can we already know that as good as nephrologists are, we're still pretty much dependent on creatinine and urine output. Cystatin C is coming along, but still not where it needs to be. And look how long it took cystatin C, and the biomarkers are going to take long too. So nobody knows where to put those yet. So really the future, I agree with you, the future is in deeper learning and what are the characteristics and patterns that the computer can see that will tell us, here's your next nephrology consult. So you show up to the ICU and say, I'm here to do a nephrology consult. And they go, we don't need you. This looks fine.
Bed 4 is going to have kidney failure tomorrow.
Exactly. One of the things I used to do before the end of the day is to round in the ICUs and look at everybody's Foley.
Right. Oh, good one.
And I used to try to predict tomorrow's consults. And sometimes I would take urine from those Foley because it's legal. And I just tell the nurse I took 5 cc's, and I would do a quick urinalysis and see what was going on.
Yeah.
So anyway, but I think that you're excited about AI,
definitely,
deep learning, and so here's the suggestions, and this is just taken from a brand new review. So this is where we are: randomized controlled studies evaluating the impact of prediction models, comparing biomarkers, and these other things that are listed, to try to still. Because we still can't do what the second slide I showed you said we couldn't do. And so today we reviewed the most common causes of AKI. All 6 varieties were mentioned and cases were shown. And these are real cases that I saw, people I knew.
Yeah.
And so they're the real deal. These aren't made up cases.
No, that's great.
And I'm lucky to have met so many people, some who got better quickly and some who needed dialysis. The one thing we didn't talk about today, it's a talk on its own, is hepatorenal syndrome. It's a kidney disease in the setting
and
of
cardiorenal syndrome.
Right. We didn't talk about those.
I think those would be 2 good topics either to do as one.
Well, you said it. They're actually they're both. It's hard to know whether that would be one talk or 2, but they're going to be separate.
Well, they're 2 long talks.
Yeah, they're pretty long talks. So we covered a lot of them, but we didn't cover the rarer causes on this table. And I circled the hepatorenal because I knew that you would then say cardiorenal, and that would be topics to discuss later. Yeah. So those are again the cause of AKI. So here's the treatments that have not worked and some that may work. So look first at no clear evidence of benefit, and these have been going on since at least the 90s. I remember these studies. They showed up in the New England Journal: calcium channel blockers and dopamine and AMP.
All the diuretics,
phenoldiprem,
right,
and N-acetylcysteine, which by the way, N-acetylcysteine makes the creatinine in everybody go down.
Right.
So the reason it worked in the original New England Journal study is because it makes creatinine go down. It's organic biochemistry. So anyway, all these things have been tried. I remember the days of theophylline and phenoldiprem.
Yeah.
None of this stuff worked.
Right.
And the Colorado group was excited about AMP. And because the Colorado group of Schreier was introducing it, people were excited.
And for a long time, there was renal dose dopamine, and then that.
Right. So none of that stuff worked out. So here's what's ongoing, and I don't know much about.
Well, because I think people hypothesized that increasing renal blood flow would improve things.
Yes,
it never did.
But it never. Again, you can increase urine output with diuretics, but that doesn't do a thing for GFR.
Exactly.
And urine output and GFR are 2 different things. Here's some ongoing trials, and if you had to guess which one of these will come up positive or helpful, what of these would you pick would be first and last? What's the best chance of working and the least chance of working from your point of view, Craig?
Oh,
because you're a country doctor.
I'm a country doctor.
I know.
Remote ischemic preconditioning.
Okay, that's actually pretty cool. I think that's one of the coolest things on there.
Well, one of the reasons is I think post-op AKI is probably one of our best targets for improving renal outcomes.
Yes, because those are
because it's a predictable injury.
And we know when the injury happens.
You're going to be injured at 3 p.m. on Tuesday.
Your kidneys are going to be injured.
Your kidneys are going to get injured.
Hopefully you're going to be okay.
Well, they will be injured. They're going through surgery. They'll just be asleep for the injury.
Right, but the thing that's surprising is this 2021 review only lists a few, and they don't seem to have a lot of,
right, nothing exciting
nothing
here.
like alkaline phosphatase. I mean, I don't know.
Wow.
I don't know. So we're still behind the 8 ball.
Where'd you get that table
and
from?
We're still creatinine. This is the same review.
Oh, okay, from that same review.
This is from
intensive care medicine.
Yeah, intensive
okay,
care
but it's new.
Yeah, it's new. It's brand new. So that's what I'm saying. Trials ongoing. I mean ongoing. And this is not, Anyway, this is where we are. So now sepsis it's hard. Sometimes we see patients where they're hemodynamically stable, and we can't see a nephrotoxin that's obvious, yet they have AKI, ATN.
Right.
And the question is, can sepsis alone do it? And this is just one slide I want to include for completeness.
No, I think it's good.
That there's a lot of different hypotheses on how sepsis may do it. And a couple of years ago, I remember there being this idea that a hemodialysis machine would be put, a hemofilter would be put in series with something that was going to take out the bad actor white cells.
I feel like there should be a slide on COVID renal failure.
You do?
You probably have one.
You do? I don't really know.
Yeah. All right, awesome. Go back to sepsis, though. Sorry about that.
No, I was done with it. I just wanted to show it, to say that we don't really know. But this is just kind of, again, a bunch of arrows.
Okay.
But
we love arrows. And you know what it means when the more arrows you have.
Right, yeah. and you hyperaroguria.
Yeah.
And you hadn't seen these slides.
No, I've never seen them.
But you did predict.
Well, I'm in your head, Alan.
Yeah, you are. So what are your thoughts about, we know that AKI has a lot of causes. You started off the session by saying that.
Oh, yeah.
So here's my question for you. Do you think that COVID-19 is just another thing that we add to the long list of sicknesses that get you to the ICU, where you get your AKI because you're in the ICU? Or do you think there's COVID-19 specific nephrotoxicity?
Specific. I think.
What is that specific, you think?
I think there's multiple things. I think there's like a direct cytotoxic injury from the virus because we have receptors for it.
Okay.
I think there's immune complex injury.
Okay.
And I think you can get ATN from hypotension and just overwhelming, hypoperfusion.
And the vasculopathy vasculitis.
Right.
Okay, because they clot like crazy. So to put this in perspective, again, since these talks that you and I have will be available for hundreds of years, we should probably put a time point on here and remind people that
we're in the middle of the pandemic.
We're in the middle of it.
Wave 3.
This is December 21st, 2021, and the pandemic started in January, February 2020. We're now onto the Omicron. Right. So what does this slide say about COVID-19? So it says, first, the epidemiology. A third of the patients that are in the ICU would develop AKI.
Oh, yeah.
Okay. And the majority of them are being mechanically ventilated. And AKI is an independent risk factor, as it is for everything.
Right.
That's not different.
No.
AKI in the ICU is bad. Well, what are the risk factors of specifically for COVID-19 that have come out? Well, again, sick patients do worse. So the older, diabetic, hypertensive, obese, cardiovascular, kidney disease person does worse. And of course, if you have ARDS, you do worse. Male gender, which is not sick patients do worse, except for men don't live as long as women. Do you have any hypothesis on why being a man, is a man got a risk factor or just lacks a protective factor? Do you think?
I would say probably lacks.
Yeah, because I'd like to know whether I'd like to know whether it's male gender and postmenopausal. So if the female loses the benefit, again, you're older when you're postmenopausal. But I'd like to see how this comes out.
Yeah. But I dialyzed a lot of young women in the setting of COVID.
Right. So again, the fact that they were young women didn't protect them from having it, and you dialyzed a lot. How many
40s?
How many patients do you think that you?
I actually dialyzed. I think me personally, not a lot,
that
but 6.
Okay, 6. Yeah, that's a lot. And then
and there were CVVHD, and half of them more died.
Yeah. So the pathophys, as you mentioned, is renal parenchyma viral infection. the immune response. They were very good at that. And all the crazy cytokines and everything else, including the hypercoagulation and the vasculopathy. And so the messages they want you to get from this review is AKI is associated with a worse prognosis and higher mortality if you've got COVID-19. It was already pretty bad. We didn't need help.
Right.
The worse your lungs are doing, the worse your kidneys are going to do because of that crosstalk.
Yeah.
And kidney biopsies that have been done show essentially
mostly
ATN. So it's, again, whatever the injuries are.
They wrote tubular necrosis. We're going to have to send them a correction.
It's okay. It's all right. But maybe that necrosis was tubular.
I think it was tubular.
So the point is, Craig, as you're saying, the point is that the pathology is mostly ATN, meaning they're not seeing a TMA. They're not. What are they not seeing? They're not seeing AIN. They're not seeing. So in our 6 categories,
right?
They're not seeing. Again, in our 6 categories, they're not seeing
mostly 4.
They're not seeing this. They're seeing this.
Right.
They're seeing mostly 4 and not the other stuff.
Right.
So what else can we say to end up today? So there's the consequences of AKI in the short and long term. And again, short term refers to when they're still in the hospital, and they're the usual suspects, just what you would consider when the kidney can't do what it usually does.
Mm-hmm.
And again, this brings up more morbidity, mortality. Increased length of stay, and dialysis has its own problems. Then the long-term consequences are the increasing risk of CKD, faster progression to CKD, increased need of dialysis in the future, and increased mortality. And we could just mention Clotho for a second here.
Yeah, I want to hear what you have to say about Clotho.
So Clotho was discovered in Japan originally in the very late 90s or the early 2000s.
They were studying aging.
No, they were studying aging. And what they found out, they had this protein,
right,
and they do what they do. They knock it out. So they knocked out, when you get a new gene, you knock it out and see what happens. So what happened to the mice that didn't have Clotho is they were born and looked like regular mice. They lived as baby mice like regular mice. But instead of living the normal lifespan,
they lived the life of a dialysis patient.
They lived a very short, like 10% of the lifespan. And not only did they die earlier, because that wasn't the big surprise. The big surprise wasn't so much they died earlier, because you're missing a gene that's important. The big news was they looked like old mice.
Right.
Their skin was
atrophied.
Their skin was fibrotic and wrinkled. Their lungs were fibrotic. Their bones looked like old mice. So it looked like Clotho was needed to not age.
And they had severe vascular calcification.
Yeah, vascular calcifications, because Clotho turned out to be made in the kidney and regulates it has some factor in calcium and phosphate transport.
It's a co-receptor for FGF23.
It's a co-receptor for FGF23 is exactly right. So what the next experiment they did was they gave regular mice, so they gave the knockout mice, when they isolated the protein, they gave the knockout mice Clotho, and they lived longer.
Yeah.
And regular mice live longer. Everybody lived longer with more Clotho. Now, when you get to the ICU and you have AKI, your life is in danger because you're in the ICU.
You know why I love the name Clotho?
Yeah, why?
It's the Greek fate.
Yeah, it's one of the fates. So which sister is it? Is it
it's the one who
spins?
Cuts the thread.
Right. Not the one
decides
that spins.
how long you live.
It's not the one that spins.
I love
because
that.
Because these are the 3 daughters of Zeus, the fates.
Beautiful.
Right. And they named it Clotho because Clotho cuts.
Yes.
You're right. Thanks for reminding me of that.
Beautiful.
So, yeah, that's a great little story. I love that story. And so when you go to the ICU, you're obviously critically ill. That's if there's ever a time you're going to need your Clotho. So one reason that kidney failure may be such a bad thing to happen to critically ill patients is if Clotho keeps you alive. Now when you need it most, you don't have it because the kidney makes it.
Right.
Kidney also makes renalase, and dialysis patients don't have renalase. When you lose your kidney, your cardiovascular disease accelerates by 5 to 10-fold, possibly in part due to the fact that you've lost things like renalase. Renalase was discovered in Gary Desire's lab at Yale, and does all sorts of stuff. It's in cancer, and also renalase turned out to be very important. And Gary's
I got to read more about renalase because it's not one I know a lot
Gary's
about.
written extensively about not only in kidney, but also apparently there's data he's got for melanoma. There's data he's got for breast cancer.
Because same thing with Clotho and cardiovascular tissue, because the cardiologists are interested.
I think
in
he's got data for for melanoma, breast cancer, and gut cancers, including pancreatic. So renalase may be a kind of a game changer, and he's got a company that does that. So we haven't. I don't know of anybody who's. I know that there's secretly been places where people have gotten clotho back, but I haven't seen
like
that
a
published
transplant.
yet. I haven't seen that published yet. Yeah, you get it back when you get your kidney transplant.
That's why I love the kidney transplant because I'm like, it's a clotho infusion.
Yeah, well, it's a kidney. Dialysis doesn't have clotho, so it doesn't even have EPO. We have to give that.
Right.
So the idea is that when you lose your kidney function, everything goes down the hill, everything, because and in the long term, you have acceleration of cardiovascular disease. Will replacement of by renalase, clotho, and other proteins, as we identify them, will that help people who don't have a transplant yet do better? Is a question. So that's the consequence. So here's the summary slide. AKI has multiple causes and pathophysiology. We outline those. It's associated with short and long-term serious consequences, including a higher risk of death. Prevention of AKI is possible, but it's not really very satisfying. Again, don't let them get volume depleted or volume overloaded, and avoid potential nephrotoxins.
One question I think it's an important topic to bring up is the question of mannitol, because I didn't see it. But there is the cardiothoracic surgeons love mannitol, and there's some data for the use of mannitol to prevent acute kidney injury in post-cardiac patients.
Now, as you know, I think it's important to mention here,
because it's FDA approved for that.
Right.
That's the only other thing.
We've also known for a long time that there's mannitol-induced AKI.
Right, exactly.
So we have, again, we have to see the studies.
Right.
And I think it's interesting. What I know for sure, because it was well documented, we have well documented case going back to my fellowship of mannitol-induced injury of the kidney. Whether or not under certain settings, mannitol may help, and they haven't used it in sepsis, so it depends on the etiology.
Yeah, right.
There may be some etiology-specific treatments,
and they talk about like volume and mannitol because the cardiothoracic guys, and there is some literature there, but I have to look.
But I haven't seen. I didn't look at the literature. Yeah. I'm sure there is, but again, let me tell you this, Craig.
Yeah,
this is such a gigantic problem.
Oh,
that if there was something that was working well,
we'd all be using it.
So the fact that you and I aren't reading this in the New England Journal,
you got it,
are up to date.
Mm-hmm.
Not that those are the only sources.
It's a smattering of little.
It's a smattering here and there,
hypotheses.
and maybe there's going to be bits and pieces we can put together.
Right.
But we don't have, other than kidney transplant.
Yeah.
We still can't. Again, to tell somebody, "Hi, you don't need a consult. Maintain perfect volume and don't give any nephrotoxins." That's not.
But I think you bring up another good point there, which is, how do we, and you did this when you did your Foley check in the ICU, when you would walk through, but really the question is not to say, well, who should I consult on, but it's to look for risk factors for AKI and somehow use machine learning to identify people who are high risk and then prevent it.
Yeah.
And just like critically ill, and they have that with the protocols we use for, sepsis, which is volume expand and all these things we do.
Well, the old joke that we used to say, even I remember being a first year fellow and using this joke. My fellow fellows and I were talking, and we'd pretend how we wanted to answer a phone call for a consult, and we pick up the phone and go, "Okay, nephrology here. Are you calling this too early or are you calling this too late?"
Oh yeah, that's good. I like it.
So it was like
that's awesome.
It was like we always felt like nothing's going on,
right?
Or when we meant too early, we meant we would get consulted,
right,
by a medical team while the patient was still in the ER and the medical team hadn't seen them yet.
Right.
We said, no.
Right.
You don't consult us until you see the patient.
See, here's my dream. There's some biomarker. There's some test, nephrocheck, that comes up. Someone gets admitted to the ICU. Instead of I's and O's, and all this stuff that we track, you just get a nephro, whatever it is, not
panel,
nephrocheck.
some sort
you
of
get
panel.
your little panel. You drop it on the disc, and different parts of it light up, and you keep doing it, and it says beginnings of AIN, and then you look at the medications, and you go, oh, this person's getting nafcillin. Stop the nafcillin. They're going to have AIN tomorrow if you give them one more dose.
We did it. We already kind of did that. We say, okay, let's have MATLAB take in the data. Exactly. Origin, you plot it.
Yes.
And in between MATLAB and Origin, we've got our machine learning. That's exactly right. We just need somebody's got to write the program.
Someone's got to come up with it. And I think we need those biomarkers like you talked about.
I agree. I agree. It's the hope. It's the hope. And the question that I have is, for AKI, where people don't need a transplant, This will be very important. And the question is, going down the line, we haven't done our CKD dialysis talk yet, but going further, who's going to win as the artificial implantable kidney
Right.
that's being developed in San Diego and Vanderbilt going to be available for clinical use before immunologically compatible pigs?
No,
Because that was a
for sure.
gigantic.
Yeah.
This year there was a gigantic milestone when the surgeon, who himself was a heart transplant recipient, took a pig kidney.
Right.
And
No,
attached
that was
it to
amazing. I saw that for 2 weeks.
yeah.
For how long? 48 hours or
That-
something?
well, no, long enough. I forget exactly how long. And I don't want to say without knowing.
Yeah.
But the patient didn't develop hyperacute or acute rejection.
Right, exactly. It was
in
amazing.
in a time period where every other pig kidney had.
That's incredible.
So it wasn't a comparison to acute rejection of a human.
Right.
A human kidney. It was comparison to where had we been with pig before.
Right.
So personally,
Super interesting.
you can decide where you put your money. But I always think that as good as the implantable kidney will be, it won't be a real kidney. And pig kidney, at the very least, is a kidney
Yeah.
with all the stuff in it.
Yeah, which will be,
With all the clotho.
How long do pigs live again?
I don't know. But I
Do
mean,
I want pig
well, the
clotho
question
or
is,
human
the
clotho?
question is, how long can a pig kidney
Live in a human.
If you took a pig kidney and kept transplanting it to pigs, maybe that kidney could, there are human kidneys that are over 100 years old because a grandmother donated to a grandchild.
I always thought, like, if we were able to, raise our own pig, so we always had our pig for our own spare parts.
I think that's kind of what's really going to happen. You are not going to be raising it. It's
No.
going to be raised on special places.
Right, yeah,
But it has to be.
exactly.
But the
Spare
idea
organs.
is that everybody will have an immunological
Match.
twin pig.
Yeah.
Here's my pig twin.
Right.
Like a mini. People talk about the mini me.
Yeah.
Here's your pig twin. So here is the last slide, as you knew, because you predicted the COVID slide, and I kind of thought, oh, Craig's going to ask about COVID. And again, we want to stress that I come in here with the slides you have not seen.
No, that's right.
You know the topic.
Oh, I know the topic. You send me some little outline. You go, Craig, here's what we're going to talk about.
I think for the people who may be watching, if there is anybody, I think what makes it vibrant is you're got to be on your toes because you don't exactly know what's coming.
No,
I don't know what question you're going to ask, and it's nice when you ask about a question I got a slide for.
Oh yeah, no, that's perfect.
But I mean, it keeps it lively,
Absolutely,
and dynamic, and also shows. Because just by listening to us, you can tell where are the rough spots in nephrology. We know something already. It's smooth talking.
Yeah.
But when all of a sudden we're onto something that's a little bit more dicey, it starts to get a little Jimmy Stewart.
Right.
Well, it could be the man.
But I think, and I've always felt this way, and this happened to me when they first came out with KDOQI guidelines in 2002.
Yeah.
And you look at all these criteria and all these things, and I just think to myself, you need to understand this stuff. I mean, this is important, and we love these things.
Yeah.
But it's just like your Excel files for knowing the correction for acid-base disorders.
Right.
You don't need to memorize these things.
No.
We need systems in place that we can get a good history. We can get the story. We know the test to order. But like even with the case I had today in my office,
Okay.
it's like diagnostics. A lot of times these things are not difficult to diagnose when you have the right tests.
Right. Clearly.
It's getting the right test panel together and knowing.
Yeah, I mean, clinical medicine is always being identify the discrete things like complement levels.
Yeah.
That turn out to segregate with different diagnoses.
Exactly. And that's how we memorize things. Our brains do it this way.
We recognize patterns. Complement levels. I mean, if you got the guy with the GN here, and you're thinking GN because of the FeNA and because of what the urine looks like, once you know the complements are normal, you have eliminated endocarditis and lupus from your differential diagnosis and other things, and PGN. But you haven't eliminated IgA,
right?
And you haven't eliminated ANCA.
Yes.
So it guides your workup because we have this discrete thing. We say, okay, which one do you want more in this guy with normal complements? The ANCA and the anti-GBM, which are both normal complements.
Right.
Or do you want the ANA?
Right.
Go, pass on, forget the ANA, hold the AMA.
Right.
I'll hold the ANA.
Yeah.
And give me.
Right.
Yeah. Because, that's now we're into a different bracketology.
Exactly. And so I think
your AI,
that's where
so
clinical decision support comes in handy.
Right. So the question is, when you're talking about deep learning and AI, is it helpful to people that don't know a lot about that? So you do. You know a lot about it.
I don't know a lot about it.
But is it helpful to people who are just starting out with this to think, because most people understand bracketology from March Madness and everything. That's,
Right,
you know,
right.
Bracketology is everything. You
Right.
get two choices, who's going to win.
Right.
It's how we do the playoffs for everything. The question is, and a lot of our diagnosis has been, I remember getting a bracketology book to identify leaves on trees.
Right.
It just said, is it piney? Is it
Yeah.
needly?
Yeah,
or is
yeah.
it leafy?
Right.
And then you go from there.
Right.
And everything, you know, is it a,
Right.
you know, the veins alternating or and you would get the right tree. And I was amazed. And I thought to myself, that's one of the things I think of a lot. Back in 7th grade when I was doing the tree stuff, the leaf stuff, I said, yeah, I bet you this is how medicine works. It was bracketology. So if you had to compare the bracketology from everything from leaves to March Madness to what you know about AI, are we in a similar place or a completely different place?
We're in a completely different place.
And tell us why.
The reason why is that bracketology is only as good as the guy who makes the brackets.
Okay.
So I could take your slides and make a bracketology program that would identify every cause of kidney failure based on what we talked about.
Right.
And so that would go through all its systems, but it's only as good, which is very good.
Of the decision points.
Of the decision points. Right. What we don't know.
Did you see, did the urine show blood? Did the urine show protein?
Yeah. Were there white cell casts?
Yeah,
Okay,
yeah,
now
yeah.
we're going down here.
It's very discreet.
Medicine? So it's very discreet.
And
it can be very complex because it can look for every
okay.
medicine and raise every possibility.
And so how does deep learning fundamentally differ from that strategy?
Deep learning fundamentally differs because it looks at all the variables that you apply in the first layer, and it does calculus on all of those inputs, and it runs them through an analysis node that then tries to minimize the error.
Yeah, certain functions.
It has it's a function
minimizer, optimizer.
Yeah, and so, but it does this to actually learn the relationship of these variables.
It wants to be fed. Feed me data.
Yeah, and then it tries to figure out what is the right answer.
Yeah.
The best example.
Yeah, I was going to ask you, what's the best example?
I think the best example, and that is a common one that people learn about, is identifying handwritten numbers. Write a program where humans can write a number like the number 3, and I want you to tell me every time you see a 3, whether a 3rd grader wrote it or a 20-year-old wrote it, you can identify 3 and all of the digits. And so these numbers can look at pixels, and they can do calculus, and they can figure out, based on the complex relationship of these lines, always they'll get a 3. They'll get it right every time.
No matter who did it. So
no matter who did it.
So what about things that we know about, like navigation programs, like when we're using Google Maps, and it seems to know where we are to a couple feet nowadays.
Yeah.
And it knows your location exactly. It has the whole map of some, it's got input from all the roads and the infrastructure. It's got satellite data, and it's optimizing your path. And it even updated with what's going on with traffic nearby.
Right.
The question is, so I turned to come to your office today. All of a sudden, there was a traffic backup that Google didn't know about because it had just happened, and it wasn't going to be severe, and it wasn't really reported to anybody.
Right.
It was couple fire trucks. So, do you think that some of the ways that these navigation programs get better and better, are they getting better and better through AI deep learning, or are they getting better because the brackets are just getting finer and finer?
No, they're getting better because of deep learning.
Okay.
So deep learning, and there's a great book by Eric Topol called Deep Medicine.
Okay, Deep
Medicine. It is so good because the first few chapters give a great history of deep learning.
Yeah.
And then he goes into all the applications of in medicine. And it is... I think good examples. Imaging really lends itself, but I think these types of things, and I think it is coming.
But what does he use in his book? What example were you impressed by in the book?
My favorite one is one I've mentioned to you before, which is measuring potassium from an EKG.
Okay, so
I love that one.
So that's a great example where there's no bracketology.
No bracketology,
and somehow or other, the number of data points extracted from not even a 12 lead, right?
It's a 12 lead. They fed 12
Okay,
leads
fed
in,
lead,
but they do it. It can be done with a single
right,
lead.
But a 12 lead,
It's a single lead. A single lead.
And so non-bracketology, deep learning algorithms.
Because you can imagine if you tried to make a bracketology, all right, well, if the QRS is this high and if this wide,
It's
and
not
if the
that.
T wave is this high and has this angle, the problem with it, and one of the scary parts of AI from this standpoint is we know it's giving us the right answer, but we don't know, there's no why. Yeah. It's a black box on the inside. Yeah. So, for instance, you apply for a loan and it's like, Alan, no, you're not going to get the loan. Sorry, AI said no loan, rejected. Okay, rejected. And it's like, but why? Yeah. What was it? Was it my income? Was it my blah, blah, blah? What is bald. It? Why did that happen? Because I'm bald. You're too well educated. You're too college educated. Right, too college educated. So, but the point is that AI is a black box, and I think they're trying to unbox that a bit so we can understand a little better.
What's going on?
Is there bracketology? What's happening?
What's happening at the micro level?
Yeah.
So okay. Well, this is great because I think that I think that it's good that our AKI talk segued not only to channel work that you did a long time ago, but also segued to a little discussion of something that's one of your passions now, which I think has a bright future.
Oh, I think
in this stuff. And so again, when I will take, but by this,
you have to take credit.
But by this argument you just made, I have to push back a little bit every time you characterize yourself as a country doctor, because I don't know that all the country doctors are as into the Eric Tobel book as you are.
That's
so
true.
We'll see. Maybe you're not quite the country doctor. Give you an asterisk with that. And so
I think that's going to be my going away present for you, the Eric Tobel book.
Okay, so great. So just for what may be coming up, we've talked about a couple other topics. And of course, we're going to get to CKD and polycystic kidney disease and dialysis. We're going to get to those things.
And cardiorenal and hepatorenal.
But I think what I'd like to get to next, and I mentioned this to you, is I've looked at all the treatments out there on countercurrent multiplication that occurs in the kidney for urinary concentration and dilution, and they're all pretty much the same. So if people are still having trouble with that, which is known to be a concept, I find it fascinating from an engineering point of view.
Yeah.
I find it fascinating from a nature point of view. So I guarantee you this: we'll do a session on countercurrent exchange and countercurrent multiplication that will be broader than anything else that's out there, to the extent that I could find it.
That sounds awesome.
And again, it's founded in nature and engineering principles, not just, by the way, we got to know this for our MCAT. Or we got to know this for our boards.
Right, exactly.
So most people learn countercurrent multiplication for whatever exam is coming up, and they probably forget it, because you could say, well, I don't really need to know that for clinical medicine. But from a physiology point of view, and from a point of view where it's always going to be with you.
Yes.
The countercurrent is part of me.
Yeah.
Because of its foundation in nature and in the kidney and in engineering. So once it's with you, like AI is with you. So I think the one thing I can promise is when we do that, it will be done and have some similarities between things you've seen before, which are all very similar.
Right.
And then it will have stuff that you've never seen before. I guarantee that.
I am so looking forward to that one. It's going to be fantastic.
And we'll do that.
And I want to thank you guys for watching. That was a great. Don't forget to subscribe, hit the like button, and also hit that bell so you get notified when we have new podcasts coming out or video casts.
Oh, beautiful.
And Alan, thank you so much. That was an awesome, again, review of a really, really important topic that we all as clinical docs deal with all the time. And that was a really good review. So be well, and I will talk to you soon.
All right, my friend. Thank you.